Hi, good morning, everyone. So we'll just wait for 2, 3 minutes. We are live on YouTube as well, and then we will start. Okay. Yes. Good morning, everyone. Good morning. Hi, everyone. Good morning again. Can we start our hosting team?
Yes, sir.
Please go ahead. I think we are sufficient to go ahead, sufficient to start.
Okay. Good morning, everyone. I am Insha Sheikh, and it is my absolute honor and delight to welcome you all to RAMCON 2025, an international conference hosted by CliMed Academy. Today, we gather to explore a crucial theme in healthcare: rationalizing medication and patient centered approach to deprescribing and managing polypharmacy. In today's world, however, this art lies in knowing when less is more, when thoughtful deprescribing becomes just as vital as prescribing. It is now my pleasure and privilege to welcome a visionary whose contributions have shaped the way we think about clinical research and patient care. Dr. Ajit Singh, the founder and the CEO of CliMed and Curio, a respected research scientist with ICMR and a dedicated educator at the Department of Medicine, Kasturba Medical College, Manipal. A PhD in cardiology and a recipient of multiple national and international awards, Sir has over 40 publications, leads major clinical trials, and serves as an editorial board of reputed medical journals. Sir, we are truly honored to have you. The stage is all yours.
Thank you very much, Insa. Thank you very much, guys. And I welcome you all, first of all, to this wonderful conference. And I'm very glad I can see a big number here. And let me tell you, we have almost 250, registrations from outside and almost 550 our interns from all three batches. Okay. So, I mean, it is for everyone. They are joining from YouTube, they are joining here, and I can see here the number is constantly increasing. It's a full day conference. So, guys, I welcome you first of all to this Rationalizing Medication, a patient-centered approach to deep prescribing and managing polypharmacy. Okay, so before I go further, let me tell you a bit about CliMed, and then we can go ahead, with the with my words and how and when it was started and how we are, going. Can we share? Yeah. Okay. So just guys, I want to show you the yes. I hope it is visible. Yeah. So guys, we have started CliMed long back. It's not very long back, but 2020, and till now we have achieved a lot. We have achieved a lot, frankly, if I tell you. Okay. So as you can see here, this is our we are working in the field of research. We are working in the field of education services, including our expertise in medical writing, regulatory affairs, pharmacovigilance, and data analytics. And definitely, we are into the innovations. We are into the research innovations and research projects. Multiple things are going on. Let me just take you through. So we have started in August 2020, and we recently in last 5 years only we got the international recognition. Right now we have 40 plus countries associated with us, in terms of students, in terms of collaborations, and we have trained almost 1 lakh students from the medical, pharmacy, nursing, dental, and other disciplines. So there are a lot of things. You can go through the website. I'll not just check here, but I'm very proudly saying this, that we have our parent entity with this CliMed Research Solutions, and that is a CRO, contract research organization, that we have started in Hyderabad. We have our base in Hyderabad and Gurugram, and then we have started our wings. First is CliMed Academy, which is skill based training and education services. Again, we have the Curio, where we learn about all the innovation. We do all the innovation, and we have all the knowledge resources for the industrial trainings in Curio. And we have CliMed Overseas, which is the wing where we train the students for the global guidance and global pharmacy licensing exams. Okay, other than that, we have started care program recently, our care and mentorship program, which is CliMed Academy research ecosystem, that is care. Okay, and we are developing the care program to develop the research in India, right? So we have CliMed Academy, Curio, and CliMed Overseas. We have multiple services in our CRO: medical writing, biostatistics, project management, clinical data management, and all clinical operations. And we provide all type of courses which train you which train you and prepare you for the industry, including regulatory affairs, medical writing, data analytics, research consultations. We have the mentorship program as well, and we have almost 120 plus long term courses, like 3 months plus courses, and then 200 plus short courses right now with us. Okay, we have achieved multiple milestones. So we got the best EdTech of the year 2024 award, and we recently got the national icon award for this. And we have other multiple achievements. I'll not go into all, but yes, we recently in our Curio has developed 30 plus skill development courses, including 10 diplomas, and overall we have 200 plus courses in CliMed Academy and Curio. And as I told you, we have trained almost 1 lakh professionals, from the pharmacy and other healthcare, affiliations. And we are, affiliated to MSME skill development, and we have ISO certifications. We have best startup, award. We have best edtech award. We recently received the Ratan Tata Leadership Award, and there are multiple flagship programs which are very famous. Like if we talk about industrial training, this is our, I think this will be our 14th batch in July. And AIML in healthcare, we run the first diploma, from 2020. Actually, 2023, we started this diploma in AI in healthcare. It was the first in India for the pharmacy and healthcare professionals. And we have our diplomas in clinical research, which is very famous. Medical writing, 17th batch. Pharmacovigilance, 13th batch. And I'm very proud. Clinical research is almost 21st batch right now. Okay, we have multiple other master certifications in the medical core areas like oncology, cardiology, AMS, gastroenterology. So you can visit our website I'll not talk much here. We have almost 160 colleges and pharmaceutical companies and medical device making companies with us in collaboration. So the list is very long, and that is about us, guys. So please visit our websites, that is climedacademy.com and curiosctri.com. Okay, curiosctri.com. You can join with us as well, as a faculty, as a student. Please join us. And now let me come back to this very important thing what we are discussing today, what we are gathered for here, that is the conference on rationalizing the medications, a patient centric approach to prescribing and managing polypharmacy. I remember our mentor and academic director, one of the academic director, Dr. Neha, Dr. Neha Suratia, who is with us, and she came up with another idea that I'll be sharing in sometime, maybe in the lunchtime or afternoon, when we are gathered for the our valedictory function. That time I'll be sharing something surprising with you. Okay, so you be with us till the end, and that is really amazing. So we were talking about some course, we were talking about something new in the domain of clinical pharmacy, for the clinical pharmacy. So she came up with the wonderful idea of the course, and then we decided that we will start with a conference. We will start with a conference on the same topic, that is rationalizing medication, and we will be focusing completely on the patients. Okay, now before I go to that, I just want to share some real time incidences. What we when I was doing my PhD in cardiology, I was dedicated to the heart failure patients and cardiology patients. So I used to see, I mean, and normally you also see in all the hospitals, all the clinics, and I used to see that how the drugs have been tapered, how the drugs have been tapered on the daily basis. Like, suppose the someone came up with pedal edema, someone came up with very severe breathlessness, very severe dyspnea on exertion, right? So we used to give, suppose the patient came to the emergency, we used to give 80 ml or 80 mg of diuretics, right? And then 80 mg of diuretics, furosemide we used to give, and then after that the patient was shifted to the ward, and after 1 hour we used to check, 2 hours we used to check, 3 hours symptoms we used to check, and then we used to taper, like, okay, the next day dose or next morning dose or after 4 hours dose will be 40 mg. Then again patient has accelerated the symptoms, then the dose will be tapered. So this is not all about how the usual doctors do, how the usual clinicians do, that okay, the one dose will be the all dose, all time dose. No, we have to look into that, how the patient is behaving to the drug, how the patient is behaving to the disease, and based on that, based on all the other the other consequences and other conditions and situations, we have to taper the dose, we have to deprescribe sometimes, because polypharmacy is again a big deal, because sometimes we give multiple medications, we don't look at the efficacious medication, but we'll give multiple medications. You go with a fever to the normal clinic, he will give you, without checking for, without making a proper diagnosis, he will give you all antifungals, he will give you all antibiotics, he will give you all antivirals. So at the end, anything, at least anything will work, right? कहते हैं ना, कुछ तो काम करेगा, right? So at the end they think that okay, anything you give, everything, at least one drug will work, right? But this is not the good approach, because that is leading to the devastating condition in the future, and right now we are facing it, that is called antimicrobial resistance, right? So similarly, in all the domains, whether it is cardiology, whether it is oncology, whether it is your general medicine, surgery, anywhere, whenever you are seeing the patient, whenever you are talking to the patient, whenever you are looking at the prescription, being a clinical pharmacy, or you are writing a prescription, becoming being the clinician, always look at like what is perfect to this individual person. Nowadays we knew, and we have the multiple researches says that every individual has the different pathophysiology, every individual has the different behavior to the drug, right? And based on that, multiple factors has come out, like genetics, like their proteins, their mRNA, different things have come out to detect that CYP45 and CYP12, so multiple things are there to check out the things. I know these are expensive, but at least you should do the basic diagnosis, and then only you should give the drugs, right? You should not go with the polypharmacy, otherwise, it will lead to, you don't know that the cost of polypharmacy and polypharmacy related side effects is, I mean, we don't have the estimate in India, but US 2018 estimate I was reading, and I take this course on medication errors. So you won't believe it is 18.6 billion, around 17 billion estimated cost of the polypharmacy and drug related errors. 18.6 billion USD per year, right? So it is very must and very important to look at the personalizing the medication, to check the individual patient, and to make the prescription based on the individual needs, right? So I think today's complete conference is dedicated to this topic, and everyone will be talking on this topic only, around this topic only, based on their expertise, right? So I would like to thank our wonderful speakers who are joining us today. Dr. Akhila Reddy, she is the HOD of clinical pharmacy from Wellness Hospitals Hyderabad. We have Mr. Said Mohsin Kadri, who will be joining us from Abu Dhabi, and Dr. Anita, she will be joining us from the Coimbatore. She is the pharmacotherapy specialist for the neurology and working at KMCH Coimbatore Kovai Medical Center. And we have Dr. Priyanshi Saha, who is PharmD and joining us from Parul Sevastram Hospital, Vadodara. She is cardiology resident pharmacist. And we have Dr. Pravalika, who is again the HOD of clinical pharmacy and clinical assistant to oncology at KIMS Hospital, Gachibowli, Hyderabad. We have Dr. Neha, who is author and educator, who is also the course director and operational associate at with CliMed. So I welcome all of them, and I would like to thank all of them for being generous and kind and accepting our request to deliver the sessions on this wonderful topic. So guys, with that, I will take it off, and I would like to hand over the mic back to Insa, because I would not like to be late to the conference. I wish you the best, guys. I wish you the best. Okay, please learn well, ask many questions, and there is only one request to all of you: please don't make the chaos in the conference. So ask as much as you can in the chat box. Your mics will be off for certain time, and you will be given a chance to ask the questions in the chat box. And sometimes in the you can even open your voice also, open your mics also. Okay, so with that, best wishes guys, and best learning, happy learning, and please enjoy the Sunday and learn best out of this Sunday. Thank you very much, Insa, for the wonderful introduction again, and wonderful hosting. Please go ahead, over to you.
Thank you, sir. Thank you so much, sir, for the insightful and thought-provoking address. Your words have beautifully laid the foundation for today's event, reminding us that rational prescribing isn't just a clinical responsibility, but a compassionate commitment to our patients. With that, I now hand over the stage to our next host, Shibani, who will be guiding us through the upcoming session. Thank you.
Thank you, Dr. Ajit and Insha. Good morning, everyone. I'm Shibani, and I'll be your host for this segment of the conference. So, our first topic of the day is minimizing medication burden in cardiovascular patients, a resident's perspective. This topic highlights the importance of optimizing pharmacotherapy to improve adherence and outcomes in cardiovascular care. To present this, I'm delighted to introduce Dr. Priyanshi R. Shah, a dedicated cardiology pharmacist. She completed her Doctor of Pharmacy from Sumandeep Vidyapith University in 2021 and went on to serve as an assistant professor at Parul Institute of Pharmacy, contributing to teaching, clinical trials, the Drug Information Center, and residency program coordination. Most recently, she completed her residency in cardiology pharmacotherapy at Parul Sevashram Hospital. We are privileged to have her with us today. Dr. Priyanshi, the stage is all yours.
Thank you, Shubhani, for the introduction. Now I'm starting my presentation.
Please, yeah.
I'm sharing the screen right now. Is my screen visible to you?
Yes,
hello?
ma'am.
Okay. Right. Hi everyone, I am Dr. Priyanshi Arsha, cardiology pharmacist, and I'll be delivering the talk on minimizing the medication burden in cardiovascular patients. Let's start this. So as this is on the polypharmacy, let's start with the polypharmacy. Okay, this is the content which I'm going to deliver today in today's talk. Let's start with the polypharmacy, guys. So polypharmacy itself having a lot of definitions at various places with a different perspective. So uh, if we see basic thing, then the polypharmacy is basically it is multiple medication. If we think poly, that is multiple, and pharmacy is related to medication. So it's a multiple medication. And if we think about polypharmacy, then the population we first think about is the elderly population, as they are already having diminished organ functions than the normal adults. So older adults are more prone to having polypharmacy than the other population. Uh, they are more of vulnerable population for the category of polypharmacy. And if we are talking about polypharmacy, then the one most important term we need to understand is multimorbidity. So multimorbidity is coexistence of two or more chronic health conditions, which is mainly present in the elderly, also can be there in all other population as well. Uh, Multimorbidity is mainly associated with decreased quality of life, self-rated health, mobility, and functional ability. That also increases the hospitalization, physical distress, use of healthcare resources, mortality, and ultimately the cost. The presence of multiple chronic conditions that mainly increases the complexity of therapeutic management for the both health professionals and also for the patients. And also that impacts negatively on the health outcomes, obviously. If any person is having multimorbidity or multiple conditions, then obviously that patient must be on multiple medications, and that puts the patient in the category of polypharmacy. So if we think about polypharmacy, then there are various definition of it. Simply, it is more drugs being prescribed or taken uh, than clinically appropriate in vision of comorbidities. Uh, Previously, there are a lot of numerical medications, numerical definitions of polypharmacy. But nowadays, which is more prevalent is uh, five or more drugs, which is being prescribed in the ambulatory setting. Previously, it was ranging from 2 to 11. Some of the people considered it as a two or more medications, some consider it as a five or more medications, some consider it as 11 or more medications. So that varies, but commonly currently we are accepting it as a five or more medications, which is given to the patient at the one time in the ambulatory setting. The optimization of medication for the patients with complex and or multiple conditions where medicine usage agrees with the best evidence. In terms of appropriateness, if we are talking about polypharmacy, then there are two most important terms: appropriate polypharmacy and inappropriate polypharmacy. There is huge difference between both. Polypharmacy, all time, it is not like something that which is harmful for the patients, because if somebody is prescribing a drug to the patient, then first first of all, that person has some of the idea about the medication uh, in regards to patient uh, and the condition. But if we think that there are some other factors like missing of the drug, lack of documentation of the medication, lack of compliance towards the medication, there are a lot of other factors which takes polypharmacy towards the negative impact of it, that we will see later on in this presentation. uh, if we talk about appropriateness of polypharmacy, then the polypharmacy ranges from the uses of large number of medications to use of potentially inappropriate medication underuse, and duplication and potentially inappropriate medications. Duplication of medications, like inappropriate medications in the context of duplication of medication drug interactions, medication used to treat side effects of other medications, and medications which are unnecessary for specific patient. But the better betterly understanding of the polypharmacy can be defined as a patient visiting multiple pharmacies which may be associated with safety concerns relating to potential outcomes such as medication duplication, drug interaction, and adverse effects. The importance of polypharmacy. Uh, if we take the dispensing data from the pharmacy and we assess it for the prevalence and incidence of polypharmacy, then we can get to know about the chronic use of medication, which put the patient on potential for the greater risk of medication related problems. So that's the area from where we can get the polypharmacy patients and we can weigh them for the risk of medication related problems. Risk of polypharmacy. At the patient level, it is mainly occur at the patient level and healthcare system level. It's very well understood that at the patient level, if the patient is having medication related problem, then it can be the one of the risks from polypharmacy. But at the healthcare system level, if there is poor documentation on the drugs which patient is taking, and if the patient is going to other prescriber, then this another one is not to like not properly knowing about the previous history of the patient and which all medication patient is taking. So because of this poor documentation or lack of the data which is patient is taking previously, that can put the patient on polypharmacy. The number of prescribed drugs increases, so there are chances of adverse drug events and likelihood of harm from the multiple drugs. It is associated with adverse outcomes, including mortality, falls, adverse drug reaction, that increases the length of stay in the hospitalization and readmission even soon after the discharge. The risk of adverse effects and harm increases with the increase in numbers of medication. The harm from the medication can be results due to multitude of medication related factors. There are multiple factors from the if the patient is taking multiple medications, and harm can occur by that also. However, prescribing to meet disease specific quality metrics could increase the polypharmacy for patients with multiple medical conditions, which increases the risk of adverse consequences and increases the patient's financial burden as well. And I think that's the most important thing. The financial burden towards the patient is the most important thing for non-compliance and even for polypharmacy. Is it is like that polypharmacy is always the risk? No, right? Because if somebody is prescribing drug to the person, then there are chances that patient is really required all those medications. So here the term comes, that is potential benefits and potential harm. If all the drugs which is prescribed to the patient, even it is comes under the category of polypharmacy, if the potential benefit of all these drugs weigh off the potential harms, then this cannot be considered as the risk, or it is having any negative impact towards the patient. All right. So there is a clear need towards adopting the term appropriate polypharmacy in order to differentiate between the prescribing of many and too many drugs instead of simple numerical count of the medication. So if we see that some patient is taking 10 medications, then it's not necessary that all 10 is harmful for the patient or having a potential risk towards the patient of medication related problems rather than the potential benefit. Now we will see some of the tools which identifies the polypharmacy. There are the first criteria came by Dr. Beer. He gives the Beer's criteria. Then the other criteria come to stop the medication. We use screening tool for older people's prescription, and to again restart the drug, we can use screening tool to alert to right treatment criteria. Also, one of the other tool for identification of polypharmacy is medication appropriateness index. And all these tools are classified into implicit, explicit, and mixed. We'll see one by one all these tools. Explicit tools mainly includes Beer's criteria, stop criteria, and start criteria. They have rigid standards and clear criteria assist with quick and easy decision making. However, patient complexity is not considered in the decision making process. It allows for comparison of patient's medication list to a set of potentially inappropriate medications and to check the medication duplication, medication and disease interaction, and medication adjustment required for certain disease states such as renal or hepatic impairment. Some of the data, according to some of the updates, the Beers criteria was updated with the list of potentially inappropriate medication by drug class and disease state. The stop and start criteria are used together to identify medications that may be inappropriate to stop. Which is mainly for stopping of or discontinuing the medication, and the alternative medication that can be started to safely treat disease, that is according to the start criteria. If we see implicit tools, then the implicit tool is medication appropriateness index. It is more time consuming process because they are mainly based on the physician's judgment rather than set criteria, but they are more patient centric and considered patient complexity. Limitation of this criteria is physician's knowledge, experience, and attitude, and are less reliable than explicit tools in clinical setting, because explicit tools having some specific factors rather than this is having more of knowledge and experience and expertise of the patients. So scales can be different for all the physician, which cannot be judged. So we cannot make this tool as identical for all the patient. Although the questions are clear and straightforward, it can take considerable time to apply the medication appropriateness index to each medication prescribed. So in this case, what we used to do is there are certain questions like these all are questions like optimal therapy for the disease and conditions, medication duplication, appropriateness of the dosage, formulation, duration of treatment, medication and disease interaction, and direction for use. All these questions we put for the all particular medication. If a patient come to us with 15 medication or 5 or 10, whatever the number of medication is, we will put all the questions for each medication. So it will take a lot of time and efforts. And also the most important thing is clinical history of the patient. So this all will take a lot of time and efforts, and still we cannot consider it as appropriate as the explicit tool. But by this we can help the proper history of proper we can put like classify the patient in whether the polypharmacy is harmful or not, and we can even make the decision of deprescribing by this tool. Now the concept come is deprescribing, which is the most important thing for today's talk. It is medication review or deprescribing interventions work best in combination with other interventions like non-pharmacological approaches, such as regular exercise, reduced dietary sodium. This all will benefit for reducing the risk of many of the side effects of pharmacological approaches. For example, if recent studies have depicted that deprescribing antihypertensive in older patients who are taking non-pharmacological approaches like exercise and reduce the sodium, then the patient will reduce the risk of falls. In older patient, it is more commonly seen that if the patient is having hypertension, then the fall is very common for the patient, even due to hypertension, which is a main side effect of antihypertensive, or it can be due to the excessive amount of like stage 2 or 3 hypertension. There is growing evidence that multidisciplinary approach to deprescribing could have potential advantage on staff workload and patient's clinical outcome. For deprescribing, there are some efforts are globally, the efforts for deprescribing are increasing, which reinforce the formation of regional and national deprescribing networks. In Australia, there is Australian deprescribing network. In Canada, it is Canadian deprescribing network. For Europe, it is English deprescribing network and network of European researchers in deprescribing. In United States, it's US Deprescribing Research Network. The aim of all this network is bringing the multidisciplinary groups of professionals together to share research and successes and last challenges. Now, the efficacy of prescribing. I collected some of the research data which depict the efficacy of deprescribing, that how beneficial it is towards the patient. So, some multifaceted interventions for reducing the use of inappropriate drugs, which comprise pharmacists and physicians for drug review, education programs, audit, feedback, geriatric assessment, and multidisciplinary team approaches. There is a systematic review in 2013, which includes 36 studies, among which 20 were RCTs, that is randomized control trials, which involves 13,906 frail older patients in various settings. And out of 26, 22 studies contains the quantitative data which report the statistically significant reduction in proportion of drugs deemed unnecessary. Like there were 22 studies said that the reduction in unnecessary drugs was had a good impact on the patient. Uh, in 2013 itself, there was a Cochrane analysis was done on 5 RCTs in for IPD patient, inpatient department medications, which led by physician, pharmacist, and other healthcare professional, and that involves 1,186 participants, and that demonstrated 36% reduction in emergency department visits from 30 days to 1 year following the discharge. So that's the benefit of doing deprescribing of unnecessary drugs. More recent review of 20 trials of pharmacist-led reviews in both inpatient and outpatient setting involving 9,558 participants showed that reduction in unplanned hospitalization in patients with heart failure. In 2012, there was a review of 10 RCTs, 10 controlled and 20 RCTs studies involves 247,674 older patients, revealed statistically significant reduction in number of drugs in most of the controlled studies. 2012 Cochrane review of 10 studies of different design concluded that interventions were beneficial in reducing the inappropriate prescribing and drug-related problems. 9 other observational studies, the cessation, it depicted that cessation of inappropriate antihypertensive agents was associated with fewer cardiovascular risk and deaths over 5 years follow-up period. Another 2011 review of 20 RCTs specific to nursing homes and involving 14,416 residents concluded that educational interventions and pharmacist drug review may reduce the inappropriate drug use under certain circumstances. Later in 2013, Cochrane review was published, which was restricted to 8 RCTs for various interventions involving 7,653 nursing homes residents, which depicted that drug-related problems were more frequently identified and resolved together with improvement in drug appropriateness. So all this research ultimately shows that interventions and measures of drug use, analysis of appropriateness did not always separate the underuse of effective drugs from the overuse of unnecessary drugs. You know what? This is a very important thing that to understand that underuse of effective drugs and overuse of unnecessary drugs when we are doing deprescribing. It is very important. Now the process of deprescribing. Okay, there are certain steps of deprescribing. First is ascertain all the drugs the patient is currently taking and reasons for each one. So if any polypharmacy patient is coming to us, first of all, we will ask patient to take all the patient or carers to take all the medications to us, whether it's allopathic medication or alternative medicine or any OTC drug. It could be anything, so that it will increase the understanding which all drugs patient is currently taking or even the previously prescribed drugs. Here, medication history is also having equal importance than the current medication which are taken by the patients. Once after getting all the medication, we can ask the patients with in the non-judgmental way that whether the patient is regular for all the medication, whether they are taking it regularly, or any other factors like it could be anything. It could be the cost of the patient. It could be the adverse event which is felt by the patient, or sometimes it is like, you know what, sometimes it happens that some patients have think that this medicine is not giving the effect to me, so I won't take this medication. So such kind of things are going on with the patient. So here first step is having very much importance, because we need to ask a patient that which medications they are taking and which they are not compliant properly. And even sometimes it occurs that uh, that patient is taking some of the medication, even though it is prescribed daily, they are taking it on a weekly basis, or sometimes they used to take, sometimes they don't used to take. In my specialization in cardiac patients, I have seen multiple times if the patient is on the anticoagulation, especially some oral anticoagulation like warfarin and uh, other than the 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 compliance of medication is most important, the having the most importance for maintaining the INR of the patient. So here the medication history is most important. Even the patient is lying, you should have judgment that whether the patient is lying or not, to escalate to the dose of the drug. Here the first step is having the history of the medication and current compliance of the patient towards the medication. That's the first step. Secondly, consider overall risk of induced harm in individual patients in determining the required intensity of deprescribing interventions. This will categorize the patient in two factors. One is drug-related factors and other is patient-related factors. First is drug-related, which is having number of drugs which patient is taking, like that itself the single most important predictor for polypharmacy. The use of high risk drugs, you know what, if we think about high risk drugs, then we should have idea about some of the drugs like digoxin, antipsychotic drugs, psychotropic substances, and more of these drugs which are having more uh, which more tends to develop any adverse event and toxicity. And especially drug like digoxin, which is having narrow therapeutic index, it is more tends to having toxicities rather than giving the effect. These are the drugs which we are, even though increased little amount in the body, then it can cause toxicity. And if it is even though it is like minimum, there is minimum decrease of serum concentration of this drug, then it can be subtherapeutic for the indication. So such drugs are needs to be very closely monitored, even though in the case of polypharmacy, if the patient is taking multiple medication, then this kind of drugs like digoxin and all, which are needs to be given more of importance, because this can not only lead to harmful effects but also may lead to mortality as well. Now, some other factors we need to consider, that is patient factors like age of patient greater than 80 years, cognitive impairment, multiple comorbidities, substance abuse, multiple prescribers, past and current non-adherence of medication. Even though along with current non-adherence to medication, along with this past non-adherence is equally important, because if patient has let's say for example, if the patient was taking some of the antihypertensive medication previously, and they just discontinue by their self and did not talk anything about to the next prescriber regarding the same, and even they are not let's say for an example, that patient is not even taking documents of it, then also it can cause some harmful effect, that patient like prescriber may again start the same medication, or the patient is having any adverse event previously and they are not even informing the same thing to the prescriber, they can again put the patient on the same medication. So such thing can occur. So patient factors are also the most important for the process of deprescribing. Okay, now the important part comes, that is assess each drug for its eligibility for discontinuation. We should monitor each of the medication which patient is taking for some factors. First is no valid indication. First of all, we need to check each medication for their indication for which it is prescribed. Is it rational or not? The dose frequency, is it in a rational way? Is patient is taking the duration of medication which was taken by the patient, is it proper or not? So there's all factors we need to consider when we are thinking about deprescribing in the case of polypharmacy. Because even if we will deprescribe, like we will discontinue any medication which is really needed, that can put the patient on the harmful effect of the condition for which the drug was given. So the indication is the prime factor which we should give primary importance when we are making the decision for the deprescribing. Next part of prescribing cascade. Okay, if let's say for example, if patient is taking 10 medication, for example, some cardiovascular medication, or along with that some nebulizer for COPD. Next for if the patient is elderly, like 80-year-old patient with the history of hypertension, COPD, and arthritis, and the patient is taking some of the NSAIDs, then we need to check whether the patient is really currently having the same state of arthritis as it was prescribed, as it was having, as the patient is previously having, or it got decreased, or what's the status of clinical status of the disease condition. And according to that, we need to check the prescribing cascade which currently patient is taking. If there is some PPIs or something which might not be indicated, or which might not be important as of now for the patient for taking, then we can think to discontinue it from the prescribing cascade. Actual or potential harm of the drug clearly outweigh any potential benefit. If we are discontinuing any of the medicine, we should check that medicine for potential benefit and potential harm. If the harm outweighs the potential benefit, then we should first go for any alternative medication, or alternative class of medication, or dose escalation or reduction. But if the benefit outweighs the harm, then we can give some symptomatic relief to the patient for the harmful effect of the drug, and we can continue the medication which was taken by the patient. Disease and or symptom control drug is ineffective, or symptoms have completely resolved if the patient was prescribed with some of the medication previously. Let's say for example, patient had fever 50 for a month back, and patient was prescribed with paracetamol at the time of the acute febrile illness. And even after 2 months of it, even though it was resolved 2 months back, if the patient is taking still taking paracetamol for the fever, then we can discontinue this medication. Next is preventive drug is unlikely to confer any patient important benefit over the patient's remaining lifespan. Okay, let's say for example, for this is okay, if the patient is having history of angina, chest pain 2 years back, and patient was put on the nitrate therapy 2 years back, and while taking the history, we got to know that since 2 years, patient is not having any chest pain or anginal pain, or he or she is not even having any coronary artery disease. And along with that, the reports, diagnostic reports, uh, like 2D echogram and ECG is normal for the patient, then we can think to stop this anti-anginal medication, that is nitrate, because it was given for preventive as a preventive strategy for the heart disease. But now it is, we can think to stop this medication, uh, and especially in the case when the patient is having some of the side effects of such medication like headache and all. And even the patient is not having side effects, we can think to discontinue this, because it is not uh, like in the span of 2 years patient is not having any adverse outcome uh, for the indication of nitrate. Last factor is drugs are imposing the unacceptable treatment burden. If the drug are imposing unacceptable treatment burden, like for example, uh, for a heart patient, if we are okay, for the patient with, let's say for example that okay, if the patient with multi-organ dysfunction, if the patient is of multi-organ failure, and then we cannot think to put the patient on uh, some of the preventive drugs like statin and all. So it can cause the treatment burden to the patient, also financial burden to the patient. Also, it can cause some of the side effects rather than giving the actual effect, because anyways patient may going to die in some period of time, like in span of 4, 5, or 6 months, if the patient is diagnosed with multi-organ failure then. So these are the criteria which we should emphasize when we are thinking for deprescribing of medication. Now prioritize the drugs for discontinuation. While deciding the order of discontinuation of drugs, that may depend on integrity of three paradigmatic criteria. First, those with greatest harm and least benefit. Second, with easiest to discontinue, for example, lowest likelihood of withdrawal reaction or disease rebound. Third, those that the patient is most willing to discontinue first, like to gain buy into deprescribing other drugs. And this all approaches suggested to rank drugs from high harm and low benefit to low harm and high benefit, and discontinue the former in sequel order. Fifth factor is implement and monitor drug discontinuation regimen. Uh, Here, we need to explain and agree with the patient on the management plan. Uh, like if we are seizing the one drug at the one time, so that the harms and benefits can be attributed to specific drug and rectify drugs and rectified if necessary. Wean the patient off drugs more likely to cause adverse withdrawal effects, re-instruct the patient on what to look for, and report to the event of such effects occurring and what actions they can self-initiate if this were to occur. Next is to communicate plan and contingencies to the healthcare professionals and other relevant parties like caregivers and family members of the patient involved in patient's care, and fully document all the reasons for and outcomes for the deprescribing. So basically, it is, if we are discontinuing one medication, we should check all the harms and benefit of the patient of the drug towards the patient, and if it is more of leading to like the deprescribing is more beneficial than the harm, and if we are discontinuing it, we can once discuss the same thing with our fellow healthcare professionals, which comes under the multidisciplinary care team. And if we finally make the decision of discontinuing, then we will discuss the same thing with the patient's relatives or caregivers, so that uh, they will also know about why we have discontinued the medication, why the what's the importance, why it was indicated and why it got discontinued, so that in future if required uh, they can also communicate with the other healthcare professional if they are going to uh, get into touch in future. Okay, this is the algorithm for deprescribing. So if we are deprescribing any medication, first we need to check that whether the medication is having any benefit or not. If patient is benefited with the deprescribing of medication. If we will deprescribe the medication, and if it is beneficial to the patient, that deprescribing it, then first we will see for the withdrawal. After deprescribing, we will monitor the patient for withdrawal symptoms and disease reoccurrence, which disease reoccurrence. And if the tapering dose, if there is a symptom, if there is any withdrawal symptom, then we will again put the patient on the medication with tapering the dose or switching the drug, and we will monitor that patient for the adverse effect like this. Then we will monitor the patient for the adverse effect, and if the symptoms are stable and not existed, then we will discontinue the therapy. And if even after tapering the dose, if the symptoms are not there, like if we are getting the symptoms, then we will restart the drug therapy. Next, if there is no benefit, we are not having any benefit from deprescribing, then we will check for the harm outweighs the benefit. If harm is more than the benefit, then we will again go for the withdrawal symptoms approach. And if the harm outweighing the benefit is not that much, then we will think for symptoms or disease drugs. If the symptoms are persisted, then again we will go for the withdrawal symptoms. And if it is not that, then we will go for the preventive drugs. If the prevention of drugs is benefited to the patient, if we are discontinuing the drug therapy, then it is benefited to the patient, then we will go for the withdrawal symptom protocol. And if it is preventive, like discontinuing the preventive drugs is not beneficial for the patient, then we will continue the drug therapy which patient was previously taking. So this is the algorithm we need to follow when we are deprescribing the drug. If someone is taking the decision for the discontinuation of drug, then there are certain factors which we need to give lot of focus on that. First of all, drug indication. Prescribers and pharmacists must collaborate for the history. Why? In the history, first we will ask the patient for why and when the therapy was initiated, which was the diagnosis at the time of initiation of therapy. Was the drug prescribed to counter adverse effect of another drug, or it was prescribed for any indication? That we will ask to the patient. Is the drug continuing to cover evident potential benefit or not? That we can assess from the drug chart of the patient. And any equally effective alternative non-pharmacological therapy is available or not. If the equally important alternative non-pharmacological therapy is there, then we can put the patient on that and we can escalate the dose of the medication. If all okay, after seeing all this thing, we need to check that all the well-tolerated drug, is it really having importance to continue it for the years or not? Because the decision of continuation depends on the review of patient's status. If the patient of heart failure coming to us, if let's say for an example that the patient has history of congestive cardiac failure previously, according to the echo report and ECG report suggested that the patient is having congestive cardiac failure 5 years back, and patient is on the proper medication of the heart failure. But if the patient comes under the polypharmacy, then we can check the current status of the heart failure, and if it is resolved, we can decrease the number of drugs or decrease the dose of drug gradually if it is beneficial to the patients. And this is how we can decrease the dose, and we can decrease the medication burden to the patient. Medication compliance. Is the patient actually taking all the drugs? That we can get to know from the history we are taking at the time of de-escalation, which was the first step in making the decision of discontinuity. the conflicting advice on benefit and harm from different healthcare professionals are important. Personal cost of buying drugs and associated burdens of monitoring. These two are main factors. Like if just for example, that patient was gone to some other healthcare professional and that person has told the patient at the time when they were gone there that XYZ medication is not having that much importance at that particular time, maybe. And if after some time, if patient is going to other healthcare profession and that person is prescribing the medication to the patient, then sometimes this is trust based kind of thing, that patient is trusting that person more than the others, so that can cause some conflict in compliance of medication towards the patient. And also the most important thing is personal cost. Financial cost is most important for the compliance of medication. By eliminating some unnecessary drugs and deprescribing may improve the overall adherence, and that will essential and that will enhance the adherence of essential drugs while reducing the cost and inconvenience towards the patient. You know what, sometimes it happens that if we are reducing the number of drugs, patient build more trust in the healthcare professional, and because that ultimately decreasing the financial cost. So this kind of psychology is given by the patient. If we are daily interact with the patient, we will get to know about such things. So that can enhance the adherence of medication by the patient. So it is very important. Next is benefit in the patient's life circumstances. Drugs are rarely indicated if they do not confer a patient important benefit within the context of one's life circumstances. For example, if the patient is of end-stage organ failure or metastatic cancer, then biphosphonate or statin are not of that much use. Like, they are important drugs, but for this particular patient, if we think about patient-centric approaches, then at this particular scenario, this we can like discontinue such medications in this particular scenarios. Benefit of the drug overweighing the potential harm. Older patients vulnerable to adverse event from the certain drugs, for example, opioids, benzodiazepines, psychotropic drugs, NSAIDs, anticholinergics, anticoagulants, some cardiovascular drugs, hypoglycemic drugs. These are the drugs which will augment the level of toxicity rather than the benefit. So these are the drugs which are giving, which we need to give more of importance when we are assessing the patient for the polypharmacy. Just for an example, if any patient is prescribed with NSAID, diuretic, and ACE inhibitors together, especially in the case of in the pre-existing kidney failure, then this three drug interaction as well as individual drug have adverse event consequences with the renal failure that can enhance the renal failure. Along with that, that can also cause hypokalemia and hypertension towards the patient. So such thing we need to monitor when we are de-escalating the patient from polypharmacy. Deprescribing, it is having mainly two categories. First is disease and symptom control drugs, for example, antihypertensive, heart failure medication. If these are ineffective, then do not cease entirely, but you can reduce the dose or use as per the disease manifestation. And second is preventive drugs. These are the drugs mainly prescribed for the prevention of future morbid events. So before discontinuing this medication, we need to think about that perspective, that is the patient is on the risk of developing XYZ condition. If yes, then we should not discontinue this preventive drugs and first think about that to future events. Next is the decision for discontinuation mainly depends on the consideration of abuse, absolute risk and benefit of treatment, time to benefit and potential preferences, estimated lifespan. Instances in which deprescribing should be considered are presenting with new symptoms or clinical syndrome suggestive of adverse event, advanced or end-stage disease, terminal illness, dementia, extreme frailty, and dependency on others, on high-risk drugs or comorbid, or on if the patient is having high risk drugs or combination drugs. Okay, if the patient is on the combination drugs, then we should consider each individual drug if there is combination of two drugs or three drugs. Let's say, for example, if we are considering ecosprin AV, which is a combination of aspirin and atorvastatin, then we will consider this as a two drug and not the one. Receiving the preventive drugs, for example, ceasing the use of statin for primary prevention after some years. Okay, so I'm ending this presentation over here. And some take-home points from this presentation are systematic approach towards the deprescribing applied by all the prescribers and supported and reinforced by pharmacists and others responsible for optimizing the use of drugs. Widespread adoption of the deprescribing protocol in clinical care has its challenges, but also considerable potential to relieve unnecessary suffering and disability. Polypharmacy increases the need for review of medication regularly, assess the utility of adding new medications, and describe when appropriate. The potential risk and benefit of drug is having paramount importance for the prescribing. Now, these are the references which I have used, and I'm ending this talk here, and I'm open for question answer, if any there.
Yes, thank you very much, Dr. Priyansi, for this wonderful, informative session. So I thank you for delivering this session and accepting our request. Over to our host. Please go ahead.
Welcome, sir.
Thank you for that insightful response, ma'am. We'll now move on to our next segment. So I would like everybody to connect with the connect with her through LinkedIn if they have any doubts. And before we move on to our next session, we'll like all the participant to switch on their cameras to take a picture for social media and conference booklet. I'll give you like 1 minute to turn on their camera, and we'll be back. I kindly request all of you to switch on your cameras for the official picture.
Thank you, guys. Thank you very much. Yes, please go ahead, Insa. No, our host, please go ahead.
We now move on to our second topic, which is navigating polypharmacy in cancer care, deprescribing strategies in oncology patient. This topic.
Shivani, I think you missed the questions. We need to take up the questions. There are some questions.
Oh, I'm so sorry. Okay, let's take some questions from the chat box. So first question is from Preeti. So the first question is, if the drug is having equal percentage of benefits and harm, then we need to deprescribe or we can continue with the same drug? That is the question.
Okay, thank you for the question. So if the potential harm and potential benefit is equal for the particular drug, then we should check the condition. Okay, this is more of scenario based. Let's say for an example that if any patient is on any hypertensive patient is on antihypertensive drug, which is uh, just see for an example spironolactone, and also patient is having heart failure. Also in this case, when the patient is having hypertension along with congestive cardiac failure, then we should put this patient on spironolactone, and we cannot discontinue this medication, and the potassium level is also increasing with this patient, then the risk and benefit ratio is almost equal. So in such case, what we can do is we can manage the potassium level with some other supplement, and and we can continue the spironolactone as it is having equal importance. And if in case when we cannot manage that particular symptom or that particular adverse event with other alternative strategy, then we can think for alternative medication or alternative class of medication which is having equal benefit for that particular indication for which drug was prescribed. Any other question? So that's the strategy we can go ahead.
We'll
Like
take another
if
question,
any
ma'am.
query.
Yes,
Okay.
ma'am. So this question is from Priyanka, and she's having a question. Is it safe to stop multiple medicines at once, or should we reduce them one by one?
Okay, all right. So we should, okay, when we are having the patient of polypharmacy to us, then first we should go for one by one medication checking. Like as I said in my talk that there was approach in which first step was taking the history and checking all the medications one by one. So we will check each medication one by one whether it is having potential harm or benefit. So it is not something that we will reduce the medication at once, or we will continue all the medication, or we will reduce one by one. It is something that we will go according to the harm and benefit, and not directly reducing the medication. See, it's not something that in day prescribing we will just discontinue the medication. We can decrease the dose, we can switch the drug, we can switch the drug class. So as per the patient's condition and as per the scenario, as per the history of the patient, we will change the medication by which patient will have most of the benefit and least of the harm. So it is not something we will reduce all the medication and or we will continue medication or we will reduce one by one. It is like that.
Thank you for that insightful response, ma'am. So due to time constraints, we'll be moving on to our next session. If you have any further questions, you can reach out to her through LinkedIn. So moving
Sure.
on to our second topic, that is navigating polypharmacy in cancer care, deprescribing strategies in oncology patients. This topic emphasizes the critical need to balance efficacy and safety by optimizing and simplifying cancer pharmacotherapy. To present this, we have with us Dr. Pravalika Vuttukuru, a PharmD graduate with a residency in oncology and currently serving as the head of clinical pharmacology and clinical assistant in oncology at KIMS Hospital. She has been recognized with the prestigious Vasavi Union Charitable Trust Gold Medal for academic excellence. Dr. Pravalika has played a vital role in reducing medication errors and improving patient outcomes through compassionate oncology care. With prior experience as an assistant professor, she has mentored countless professionals and has been an invited speaker, panelist, and judge at national and international platforms. Her recent work includes contributions to stem cell transplants and CAR T cell therapy. We are privileged to have her share her expertise today. Dr. Pravalika, the stage is all yours.
Dr. Pravalika, please unmute yourself. Yeah. Please unmute yourself. I think it's not. One sec. Oh, you have left. Yeah, now you can unmute yourself. I think you were not the co-host before. Yeah, please go ahead. Yes, yes, now please go ahead.
Yes. Good morning, one and all.
Good morning, ma'am.
Good morning, one and all. Hope you all are sitting with waking up on Sunday for the conference. So I would like to start off here. So, guys, cancer, when you talk about cancer, one second. Dr. Ajit, are you getting any resound?
Sorry.
I'm able to listen to my own voice.
Not now. Previously it was, but right now it's off.
Now it is okay? You
Now
can
it is
hear me?
okay.
Am I audible?
Yeah, now it's okay. Perfectly fine. Pravalika, please go ahead.
Am I audible?
Yes, you are.
Guys, please let me know, am I audible?
Yes, yes, you are.
Am I audible?
One sec, I'll call her.
Okay. If I'm not audible, please let me know. Actually, Dr. Priyanshi has outlined the deprescribing process. It is not much difference in oncology settings also. So we'll start here. First of all, this cancer, okay? Let's have a small introduction about cancer. It's among the most devastating group of human illness, exhibiting with millions of deaths across the globe. And the burden of cancer incidence and mortality is growing worldwide. Okay. Breast, lung, colorectal cancer, stomach, and prostate cancers are the most among the prevalent types of cancer, with occurrence rate of around 46%. And cancer has a wide variety of clinical presentations which could hinder patients' daily functioning and quality of life. See, typically surgery, radiation, or systemic therapy. What is it? Systemic therapy, chemotherapy, hormonal treatments, targeted biological therapies are all used effectively in the management of cancer patients. As we all know, patients with cancer are often prescribed with medications to decrease their initial symptoms and followed by chemotherapy and supportive medications. And multimorbidity is like it's a health crisis that affects the individuals and challenges healthcare system. Okay. When the patient is diagnosed with cancer, that doesn't mean that patient is only having cancer. Priorly, he would have been diagnosed with multiple other ailments or multiple other comorbidities. But the cancer treatment and the normal treatment is entirely different. Patient need to receive his treatment for his other conditions or his other diagnosis other than the cancer. But the treatments have to be monitored because the anti-cancer drugs are narrow therapeutic index drugs and also they affect almost all the systems of the body at different levels of treatment. Okay, you can see here polypharmacy, prescribing patients, deprescribing patients in oncology. Okay, it is nothing but reducing medications safely to improve quality of life. It is not completely cutting down the medications, is called as deprescribing. There are many things that you will consider in deprescribing. Okay. So, guys, I'll ask you one single question. When somebody tells you See, one of my relative, one of my friend, on the person known to me is undergoing cancer treatments. The first thing that comes in all of your mind, what it is? Can you please type in the chat box? What comes to your mind? The first word that comes to your mind when you hear cancer treatments or chemotherapy. Come on, guys, type in the chat box. Radiation, multiple medicines. What else? Why they got this cancer? Okay. What else? Side effects. Very good. What stage? Listen, you are only typing the answers. Toxicities, side effects, quality of life, adverse effects, hair fall, bald head. Yes, one and all the same. So, when you see risk benefit ratio, okay, always we tell when you have more benefit, you will have to give the drug. If you don't have benefit with side effects, you will have to stop the drug and choose the other drugs, or you will have to go for non-pharmacological interventions. But in case of cancer, it is not the same thing. You will have to treat cancer that is more beneficial to a patient in addition to side effects. There will be side effects. There will be severity of side effects. Like when you go for CTCAE grading criteria, also up to grade 5 toxicities. Irrespective of patient getting toxicities, you cannot stop cancer treatments. That is the reason you will provide them or you will prescribe them with additional supportive care medications. And depending only on the severity of side effects, you will have to de-prescribe the primary medications to a patient. In simple, what is this de-prescribing? It is nothing but a planned and supervised process of dose reduction or stopping medication which is causing harm or that does not have benefit to the patient. And de-prescribing is a part of good prescribing. Okay? You can see here there's so many pills. When you cut down them, the medication adherence, which is mainly important, that will improve. Our goal should be increasing the medication adherence of a patient to improve the quality of life and to achieve benefits to decrease his disease symptoms and lead a quality of life with good quality of life. That should be our goal. And you should decrease the pill burden. Means the number of intake of pills should be decreased. Even that is also de-prescribing. So what is the goal of de-prescribing? It is to reduce the medication burden and harm while improving the quality of life. Reducing doses or stopping medications can be difficult sometimes when the original reason for the medication is unknown. You see, some people, they keep telling you, I have been taking this medication since 10 years, 10, 15 years. Psychologically, they are used to that medication. Okay. Maybe they would have not approached a doctor until a new symptom has come after 10 years. Okay. And they're used. Morning they get up, they take that medication, they are very well fine. But that medication is of not use for the patient because the symptoms have been subsided long back. When the doctor understands that, okay, that patient is taking a medication but is of no use. Okay. Then the doctor cannot immediately tell the patient to stop the medication. Because psychologically, sometimes prescribers are worried what might happen if a drug is stopped abruptly or needs to have the dose lowered slowly. So, when you see guidelines, when you see for any disease guidelines, every guidelines will suggest only to add the drugs or to prescribe the drugs in case of so and so condition. But the guidelines does not address when to stop the drugs for a patient, and you cannot stop any drug as you wish or abruptly. As like previously Priyansha, there will be some withdrawal symptoms and psychologically patient will be thinking that no, today something had happened to me, it's just because I have not taken that medication. So you have to keep in mind all these patient parameters, age-related parameters, why the drug is prescribed, from how many days or how many years the patient is on medication for what is his output, or what is his feelings after taking the medication, how he is feeling, what is the recovery status. Everything you will have to assess the patient completely before you go for deprescribing. Okay, and there are different classes of drugs and different criteria will be there to stop certain kind of medications. Okay, how deprescription have to be done according to guidelines, and when to stop the medications, and how to do safely, and impact of deprescribing the medications. So when you deprescribe the medication abruptly, or when you taper the medications and then deprescribe for a patient, you should have an evidence. See, when you go for class of corticosteroids, corticosteroids are very commonly used with anti-cancer therapies, to prevent vomiting and to prevent hypersensitivity, and also, postly after chemotherapy, prior to chemotherapy, and in emergencies. Many places corticosteroids are widely used in anti-cancer treatments. Even it's a part of many induction protocols for acute lymphoblastic leukemia and all this. And around 25 to 27 days, you will have to continuously give prednisolone to a patient in induction of ALL, a part of BFM 90 protocol. At that point of time, we suddenly don't stop the prednisolone after that days. Last few days, we keep tapering the dose of the patient and then stop it, so that you don't get any other adverse effects that will be related to the steroids. Suppose, for example, the patient who is diagnosed with cancer and is on anti-cancer treatment. Okay, then what will happen? The patient will be, if he is a known diabetic and he is already on oral hypoglycemics or insulin whatsoever, corticosteroid will always increase the glucose levels. So when the patient starts monitoring his glucose levels during the course of chemotherapy, they are always slightly higher. That doesn't mean that their HbA1c or their sugar levels are not in control. It is because of the dexamethasone or whatsoever, the dexamethasone that is used as a part of pre-medication during chemotherapy. So they'll have to consult their physician in charge regarding the tapering of the doses, and it cannot be done as you wish. And another thing is, diet modifications will be suggested to the patients suffering with cancer and uncontrolled diabetes mellitus. Okay, and you should even counsel the patient not to get worried in case of such situations. What is the harm of continuing medications? We'll discuss all this with case studies, patient values and preferences. See, some patients will keep telling, Madam, I've been taking B complex since 5 years and I'm very happy with that. I'm very fine only because of my B complex medications. Okay, something like then you will have to think an alternative solution, or to tell. Some people will be telling, ma'am, from 7-8 years I've been taking pantoprazole, my father have been taking, is very fit and fine, we are used to that medication. And you should know what will be the adverse effects of taking of PPIs for long term. Okay, and associated costs with deprescribing of medications. So when you deprescribe a medications, how the costs are cutting down. All these things you will have to keep in mind. And when you're having guidelines, when you're developing a guidelines should contain when a medication should be continued or when it should be stopped. If it would hurt a person, why did it 2 times? It would hurt a doctor if he is not deprescribing a medication that is not useful for a patient. It would hurt a person psychologically sometimes if doctor will tell don't take that medication. Maybe that medication would have been prescribed by their own family physician or very known person at that time when the patient was really in need of, and that started working, and still the patient is prescribing. So there will be, all the psychological disturbances to the patient also. And you should even know how to deprescribe safely, or how you have to cut down the medication from the patient's medication list. And also, you should even just not deprescribing. For some time, you will have to monitor a patient for the symptoms and what is this outcome after deprescribing, how the patient is feeling, maybe psychologically, maybe with respect to the disease, with respect to patient condition, everything you will have to monitor a patient, and then you will have to escalate or de-escalate again after you start de-prescribing. So you will have to even know when you prescribe certain kind of medication, what you will have to monitor in a patient. So there is something called as grade criteria, nothing but grading of recommendations, assessment, development, and evaluation. So when determining the quality of a recommendation, you will have to check quality of supporting evidence. So you should have evidence, okay? Whatever you treat, whatever you do, clinically, you should have a supporting evidence. Okay, this evidence says you have to taper corticosteroid dose and then stop it to prevent the adverse effects or to decrease the severity of adverse effects. And when you are giving patient with anticoagulants, how you will have to do. So for everything, when you are prescribing anticoagulants to a patient, what you have to see, what is the role of anticoagulants in CVD? What is the role of anticoagulants? Like, low dose aspirin and all, when you use in diabetic patients, when you're doing it in multiple myeloma. So you should have a supporting evidence why these are used. Patient may not be diabetic, but still you may require anticoagulants. Why do we require? For that, you need a supporting evidence. So then only you should do it. And benefits should always outweigh the risks. And you should always consider individual values over preferences. Okay, and wise use of the resources. And there you should use your clinical expertise and also guidelines to safely de-prescribe. Okay, and clinical considerations. What are all the clinical considerations that you will have to choose when you're developing a guidelines? What factors warrant continued use? How can patient be engaged in the de-prescribing process? How should tapering be done? Tapering approach should be there. And also, what should be monitored and how often you should monitor after you de-prescribe, how to manage the recurrent symptoms. For everything you need an answer. Okay, so you should agree to appraisal of guidelines and research for evaluation. Okay, see like this, the algorithms have been developed. So when you are developing, okay, you start talking about some PPI. Why is this? Why is patient taking this drug? You should know why the patient is taking this drug. Okay, different people will have, see, GRD also you will give, even when you're giving antibiotics also you will give pantoprazole. So, but you should know why in an individual patient, the patient is taking this drug. There may condition A and condition B. Condition A, you can recommend de-prescribing and you will have to monitor and manage the recurrent symptoms, as I told you previously. And condition B, maybe this requires continuous use of that medication. You cannot stop that medication. So you will have to continue the drug. So like this, you will have to develop the guidelines for individual class of drugs or individual drugs. And dosage availability, what kind of doses are available? If you want to taper, even the formulation should be available, because you know that all the formulations, even if you get 8 mg, sometimes you can't break the into 4 mg and give some gastric coated tablets. If such tablets are there, you want to cut down the dosage. You cannot do it when the formulations are really not available in the market. So you will have to check the dosage availability of the drug that you want to taper or you want to stop. If you want to taper, you need to check the dosage availability in the markets. And patient, what are the side effects? And non-drug management. Suppose the doses are not available, the required doses are not available for a patient. Then can you do some non-pharmacological intervention, that you can stop the drug and then start with non-pharmacological, so that will be very easy. You should think even that way. When you can taper with the doses available, you should see that one. And non-drug management, non-pharmacological, if you can manage the situation, you should consider that and you should try out. When the risk is not so much that when you stop a drug, patient will develop that severity, and patient can manage with non-pharmacological treatment, you can try out and check. So if it is working, you can stop the drug and can implement or insert these non-pharmacological interventions in the patient. Like this, you can develop guidelines for individual drugs. And when these cards or algorithms are available, it is very easy to, this will be available like a checklist, and then you can go ahead with the deprescribing process. And mostly what happens, with increase in age, so many things will change in people. So, and another thing is the increasing pharmacotherapeutic burden by this polypharmacy will result in non-adherence to the recommended course of treatment and also increase of drug-related toxicities. And when patients reach this terminal stage of illness, their responses to medications vary, which is certainly due to variations in what pharmacokinetic parameters. And in light of these things, so what we'll suggest to patients, medication use in patients with life-limiting illness. It should be routinely assessed for potentially inappropriate or unnecessary medications to reduce polypharmacy and also complications associated with. So start or stop criteria will be used. Okay, another one is, that nutritional problems will be there, hearing loss will be there, dizziness will be there. And in patients, the intake, the appetite, everything will be decreased with increasing in age. So you have to consider using multiple antihypertensive medication, monitoring BP, and with increase in age, they'll have so many sleep disorders. Some patients want, medications to sleep. Some urinary incontinence will be there, and osteoporosis. So for all these, even with anti-cancer therapies, breast cancer and all, for post-menopausal women, when they finish chemotherapy and they start on these hormonal therapies, calcium supplements are given with letrozole and all these things. So all the pills, number of pills that a patient needs to take with increase in age will increase, and also their liver functions, their kidney functions, everything will decline. At that time, because of that, there will be more chance of adverse effects. And sometimes the patient may have diabetes and all. Along with anti-cancer therapies, patient may not be having a good appetite. In that case, the diabetic medications to be tapered. If not, patient will go to hypoglycemia. And you know that when you see, dexamethasone will increase the glucose levels, and his diabetic medications will decrease the glucose levels. So you will have to consider and also modify the doses of anti-cancer drugs. Suppose if loss of appetite is there, and dexamethasone increasing your glucose levels, and your diabetic medications are decreasing your glucose levels, sometimes the adverse effects are masked. So the patient should be carefully monitored. Okay, all that should be considered. And sometimes because of decrease in calcium and all, sometimes there'll be increase in falls because of neurological diseases and side effects of anti-cancer therapies also. So it is all, synergistic effects of this or additive effects of this anti-cancer therapies along with the other medications that are commonly used. Okay. And you see, polypharmacy. Polypharmacy, you have to decrease number of pills or number of medications that a patient will take. You see, some patients will come with one bag of medications, around 20, 25 medications I have seen. And I have seen a patient who has been prescribed with letrozole and calcium, wherein which, that is very much needed for a post-menopausal woman, letrozole and calcium. And she has been having some neurological issue, and doctor has prescribed with multiple uh, supplements. Along with that, she has calcium citrate supplement also. Here they have given calcium carbonate where Shelcal. There she was taking another calcium citrate. So she was about to leave the ward, and then she was showing me the medications. Madam, can you please tell me which supplement should I take, which I should not take? So I was just taking the medications. I will take this one, I will take this one. See, citrate will have more absorption. The amount of calcium that will have bioavailability for citrate is higher than this carbonate. And already she is taking citrate, and she went and purchased even Shelcal. So you can see the amount of calcium she would be taking. So then I could tell her, please don't continue both together, that you will have to start on calcium citrate first and complete all the 20 tablets which you have for this month, and then continue with the calcium carbonate. So when different brands of drugs are prescribed from different physicians, when they go for different consultations, the medication reconciliation have to be done so that the pill burden will reduce and adverse effects also will reduce. And when you see uh, this PPIs and all, I see most of the our anti-cancer prescriptions have pantoprazole in discharge medication. And when gastrointestinal, this gastro department people, when they prescribe, they usually prescribe esomeprazole and domperidone combination. There we have vomiting also. Again here, the patient will be having ondansetron as a supportive care medication. See, the drug duplication have been happening for the patient in terms of PPIs and also, vomiting medications in supportive care. So the patient is taking more and more drugs. So when there is multiple consultations for a patient, a clear medication history interview have to be performed, and then the drugs have to be finally given in a single discharge summary when he had multiple, like multiple referrals in a hospital, gastro referral, nephrology referral. So different doctors keep prescribing, and each doctor does not know what other doctor have prescribed. Maybe their medications also require a PPA and their medications also require a PPA. And finally, when the person or a clinical pharmacist is auditing for a discharge summary, you will have to check all the medication and how to prevent the drug duplications. And we have seen many prescriptions, patient will be on bethanocol, uh, and the patient is a known case of asthma. And in asthma, bethanocol is contraindicated. So that will be there in the discharge summary added. So you will have to talk to the physician. You should know about the drug interactions. You should know many patients, they'll be telling, many patients will be known case of thyroid, and people will be taking pantoprazole as a part of discharge medication. There have to be a gap between thyroid medication and pantoprazole, a minimum of 4 hours. So how you will have to tell them, take a thyroid medication in the morning, and then you will have to take pantoprazole half an hour just before food. There'll be a time lapse. So all these things, where you have to cut down the medications, all these you will have to check in case of anti-cancer therapies. So what you will have to remember when you want to de-prescribe a drug for an anti-cancer patient, you will have to stop the drug. Either you can change the frequency. Changing the frequency is also de-prescribing. Tapering the dose, decreasing pill counts, combination drugs, discontinue with non-pharmacological interventions. You can use all these strategies, you can use all these ways to decrease the dose of the drug or number of pills that is entering inside the patient's body. Okay. When I tell you stop the drug, okay, when can I tell you? You know that people who are taking, see, what kind of adverse effects a single patient or an individual patient will face after anti-cancer therapies is individual, and the severity is also with respect to individual patient. There you cannot tell in anti-cancer therapies, you cannot tell, okay, for every patient you do this. There are some patients who will be having, you have to consider their age. So many parameters you have to consider when you want to even prescribe a drug, supportive care medication to a patient. Maybe from previously he was having severe body pains. If you are giving an Taxol formulation to a patient, the patient may have severe the side effects more than the patient who previously don't have body pains and all. So for that patient, you would have to consider choosing an alternative formulation of Aqualip, which is having minimal side effects. And supportive care medications may increase like Ultraset. Ultraset is combination of tramadol and paracetamol. So sometimes what you will do, patient might be taking tramadol alone. And when you're prescribing Ultraset to a patient, that is containing both tramadol and paracetamol. So you will have to again check out what is the dose. And if the patient for first cycle you do prescribe and you tell them, you have to counsel the patient regarding that, and you have to tell them to take that medications. You know that the same Ultraset when it is given in a different cancer, it also has an adverse effect of constipation. So guys, think where to stop, where to make it, SOS, or when necessary, or you have to change the frequency of medications. That is when you are using hormonal pills, when you're using targeted therapies, when you're doing oral chemotherapy, all this you will have to see. Sometimes when the dose is high, you will have to keep, when I told you about, the availability of doses. Suppose one day you give 2 mg, you should not break the pill. Then they will choose giving 2 mg one day and 4 mg one day. Like that also we'll do depending on the PK parameters after evaluation and by assessing the severity of side effects in a patient. Okay. So what is this deprescribing palliative care? It is a process of reviewing and stopping potentially inappropriate medications in order to improve quality of life. So there's something called as ONCPAL deprescribing guidelines. It's a useful tool to support the process for patients with a limited life expectancy. Limited life expectancy means suppose the patient is going to die, like completely lose his life within 1 year, and you cannot burden a patient with lots and lots of medications and lots of IV. You will have to taper the medications and you have to reduce the medications as less as possible when there is no use and when there is no benefit to the patient. And there is a systemic process of reviewing individual medications and their appropriateness is recommended. So there is something called as OncoStrip. This OncoStrip polypharmacy assessment tool, it is used for discontinuation of potentially inappropriate medications with respect to patients who have limited life expectancy. Okay. And this OncoStrip, it contains 5 steps. Okay. What are the 5 steps? 5 steps are nothing but questioning the patient about their medication use. Next one is conducting a structured pharmaceutical analysis by a pharmacist. Means what are all the conditions he's having, what all the medications the patient is taking, what is the frequency, how many years he is taking, the complete medication history have to be taken by a pharmacist. And agreeing on an optimized treatment plan by a physician and pharmacist. Next, making the new treatment plan definitive through shared decision making with the patient. So you'll have to talk to the patient why you are cutting down the medication, what is the need, how it is going to help him out, how it will affect his quality of life, how it will affect his disease condition. Everything you will have to talk to the patient. Then following up and monitoring. So you will have to follow up, after you implement your new treatment plan, you will have to follow up the patient. Okay, that is how you will have to take care. And there's some tools that you will be there'll be so many steps for this start or stop criteria and medication appropriate needness. So what is called as polypharmacy anamnesis? It is nothing but it's a steps objective was to compile all the pertinent data regarding the patient's medication usage. So what do you cover under this polypharmacy anamnesis? Drug type, dosage, indication, when did the patient start his medication, who is the initial prescriber, what is the effect of the drug, what are the adverse effects of the drug, what are the practical issues, that is practical issues means such as complaints, non-compliance may be because of non-affordability, what is the reason for non-compliance, whether adverse effects, everything you will have to do. That is nothing but polypharmacy anamnesis. And next one is concise geriatric assessment. Adult comorbidity evaluation will be done, okay? And ECOG score, that is Eastern Cooperative Oncology Group, performance status of the patient will be assessed, like grade 0, grade 1, grade 2, grade 3. So whether the patient is able to perform his daily activities, all that you will assess. And polypharmacy analysis. So this pharmaceutical analysis was framed by the assessment of 8 potential drug-related problems. The need for additional drug therapy, the need for unnecessary drug therapy, ineffective treatments, potential adverse effects, clinically relevant contraindications or interactions, under or overdosing, and practical drug use issues or optimizations. Okay. And this recently developed OncoStrip list of medications is eligible for deprescribing in older cancer patients. And it will allow us to identify what are the potentially inappropriate medications. Okay. And next one is polypharmacy treatment plan. After you analyze all these things, the treating oncologist and hematologist, okay, they'll be given access to all the data of this patient. Once the clinical pharmacist assess all this data, and this data will be sent to the medical oncologist. So what will happen? The medical oncologist will outweigh these benefits and risks with respect to his medication history and along in combination with the treatment of cancer plan. So when this can be done by a pharmacist, the assessment and tapering and providing a good quality cancer care treatment is very easy for a physician. Based on the adverse effects of those drugs and considering the adverse effects of anti-cancer therapies, the oncologist will decide the treatment plan, what medications to stop and what not to stop, and what are the tools non-specifically that are used for cancer patients. Mainly the Beers criteria. The Beers criteria is like a frequently used method to de-prescribe the overall in the overall geriatric population. Okay, and this is usually applied in palliative cancer population. Okay. And next one is start or stop criteria. It is nothing but in areas in older people currently represent a very serious and growing public health problem. And polypharmacy and inappropriate prescribing are well-known risk factors for adverse drug reactions, and which will cause so many of adverse clinical outcomes in older people. Okay, and this inappropriate prescribing encompasses so many potential prescribing omissions. And this should be very much, including the list of this potentially inappropriate medication, you will have to start or stop the drugs. What is something called as medication appropriateness index? It is nothing but is a questionnaire to assess the futility of the drugs that are used in the treatment. It can be used to determine why this discontinued drug was inappropriate. Okay, all this you will do. In oncology setup, you will have to use patient and caregiver goal. What is their caregiver? What is their goal? What is the frequent continuation of potentially ineffective therapies may also be the result of poor communication and also insufficient shared decision making between patients and prescribers. So when there is lack of communication and all, there will be continuation of this inappropriate medications in a patient. And to overcome this, you will have to the patient will have to talk to his family physician and discuss the risk benefit ratio of drugs and also careful observation of symptoms during following weeks. The goals of care also should be periodically reevaluated, and also when the situation gets worse, to make sure the treatment target stays in line with the patient's preferences. And life expectancy. uh, so you have so many calculators for life expectancy, and when the patient is undergoing the treatments and all. So if the life expectancy is 1 month or 1 year or few months, and you should have to discontinue medication, and reviewing medication should be an ongoing process, because the patient may be taking some over the counter drugs and the substitute medications, that one have prescribed. Like how I was telling you, one physician would have prescribed Shelcal and one is citrate. So you know that citrate is more beneficial than Shelcal. So you can ask them to continue that and then stop this, or you can ask the physician to assess. And medication appropriateness. There are several factors, for determining whether drugs may no longer be necessary. What is the risk of damage may outweigh the risk or benefit. All these you will have to see. Time to benefit. So there is time to benefit. Suppose you are using, for example, statins. So the time to benefit of the drug may take months, and the life expectancy is also in few months. So you need not use statins in that patient. So all these you will have to consider. And you will have to identify what medications to cease. See, when there is a polypharmacy, yes or no. If yes, identify what is the inappropriateness. Okay. And identify the disease state, which state of cancer, what is his disease state, whether it's controlled diabetes or uncontrolled comorbidity, any other disease state along with cancer, what are the drugs prescribed. preventive agents plus symptoms, anti-neoplastic or symptom-oriented care. And what are the guidelines used? Beers criteria, ONC per OncoStrip Beers criteria. So you will have to identify the medications to cease and then you deprescribe. Check for medication if there are no polypharmacy. And you will have to check the medication for appropriateness or appropriate indication. Symptoms are not improved, then you will have to check again. If symptoms are improved, monitor and you will have to review. So what are the medication classes? So first thing is you have to identify the medications that you want to stop. A multidisciplinary team discussion aids in determining which medication to stop using. Drugs with no obvious benefits. Okay, it is vital to address medications that take a long time until benefit outside the patient's expected lifespan, such as statins that take longer than a year to provide a benefit, being ineffective in patients with a short expected survival time. So there is no benefit after a particular age, independent of patient's life expectancy, to prescribe these drugs. And drugs with undesirable adverse effects are no longer indicated, and those are inappropriate in older people. So you will have to use stop criteria, Beers criteria to stop the drug. And you will have to plan and implement this cessation. The medications without a clear benefit and some of the medication with undesirable adverse effects can be selected for deprescribing. Okay, that you will have to check. And another thing is when you are seeing for these medications, okay, see statins, antihypertensives, gastric protection, and oral hypoglycemics that I have been discussing with you people. They are saying this will not be required, this is not required, why it is not required. All these you will have to see. I told you about statin. When you consider antihypertensives, there will be changes in the blood pressure levels in the patient. Then you have to consider why you are giving statins. Can you give statins or not? What is the point? Okay, and antihypertensives, you will see there'll be BP alterations in blood pressure alterations. Some people who are undergoing cisplatin and all, they're having so much of electrolyte imbalances. And the patient is on antihypertensive medication. They'll have to monitor blood pressure. And for gastric protection. And in case of gastric protection, when you see many people will be taking medications for longer time, whether it is a GRD condition or whether he is on, suppose when the patient is on chemotherapy, what will happen? You usually give PPIs in the discharge medication. And when you are giving PPIs, people start using. Once the chemotherapy cycles are over and the patient is on maintenance treatment with targeted therapies like trastuzumab or pembrolizumab, all these things, even still what will happen is sometimes uh, people start thinking, okay, this is also chemotherapy, so I'll have to take, I will have the chance of gastritis, so I'll have to take this medications. Okay, and he'll be continuing the medication. But usually you don't require, unless there are symptoms, you don't require to prescribe those medications for the patient. So you can deprescribe that medications after talking to the patient and explaining them that they do not require that medication. Okay, and another one is gastric protein, oral hypoglycemics. I told you about the use of dexamethasone as a pre-medication. And pre-medication, because of that, sugar levels will be high. So you will have to taper oral hypoglycemics in the patient. And at some point of time, patients with cancer may transition from treatment with curative intent to the palliative care. At this point, again, you will have to cross-check benefit risk ratio. And then you have to see whether the drugs are prescribed as primary prophylaxis or what, why it is done. Okay, there's a study, okay, the largest study which was researched a patient cohort from Sweden, including more than 150,000 individuals. They found that last month of life, 60% of patients were on continued antihypertensive treatments and lipid lowering agents and on minimal mineral supplements. So all these are not required in last stage. Just you have to check the quality of life and you have to reduce the pill burden in patients. Okay. And see, I'll tell you some examples. See, in some urothelial carcinoma. So when in urothelial carcinoma, one of the protocol or one of the combination of drugs given for the patient is gemcitabine and cisplatin. So what will happen is, you know that cisplatin has ototoxicity. And when during the medication industry interview process, when you find patient is an antihypertensive, means is a hypertensive patient, maybe he's on some medication. So you know that if the patient is on loop diuretics or patient is on aminoglycosides, so the ototoxicity will increase and the incidence will increase and the severity also there will be chance of increasing because both of them have similar side effects. Then you have to consider according to patient condition what antihypertensive should be given and how it should be managed. And you know that cisplatin is a very highly nephrotoxic drug with so much of electrolyte imbalances. And for such kind of patients, aminoglycoside should not be used because they potentiate the adverse effects of cisplatin. And you will have to encourage non-pharmacological treatments in these patients with so much of oral hydration and electrolyte replacement. Sometimes you're using antihypertensives and because of some electrolyte imbalance of cisplatin also, patient may have giddiness. And you know, when sodium levels are low, you know, patient may have chance of developing neurological symptoms. So these antihypertensives intake and then the symptoms that will be occurring because of this electrolyte imbalance cannot be judged sometimes unless a blood test is done. Suppose if the patient is taking a cisplatin in head and neck carcinoma along with radiation, there will be so much of dehydration and there is more chance of patient having electrolyte imbalances and patient getting admitted. And these loop diuretics will additionally potentiate the effect, not only the ototoxicity and other side effects also. And the patient will be having lot of pain, you know, cancer and pain are like jumbo and combo. Uh, and these jumbo means very big, combo means you require. Okay. So supportive care medication. Suppose you are giving Ultracet BD for pain for 5 days and the patient is very well fine and you know the area of head and neck the patient is suffering may not have pain. Some people tolerate with very well, maybe engage, sometimes they tolerate very well treatment, and for them you need not tell take it as BD for 5 days and then take it SOS directly. You can convert it off, you can tell them you can take SOS for pain, or initially if you know, suppose that is when you're doing for pain. Suppose, you know, gemcitabine. Gemcitabine is having very severe, you know, very common side effect of constipation. And, you know, Ultracet. This also have an adverse effects of constipation. So, when you are giving a pain medication to a patient with the similar side effect, you know, already the patient may be of, in older age, he's having complaints of constipation and he cannot eat so much and you're giving Ultracet for pain, then what is the funda? What is the rationale? After the first cycle, if patient complains of constipation, what you're going to do? You are even prescribing syrup Cremafin plus, you know, 30 ml at night if you have constipation. Instead, you can change the pain medication. When the patient don't need it for pain, you can encourage him with all non-pharmacological interventions. You can counsel the patient for the complaints of constipation after taking treatment with gemcitabine. And then what he'll have to do if he has pain, you can start with a Dolo, simple Dolo tablet. And everybody does not require Ultracet. Okay. And if he is fine, no constipation problems, the severity of pain increases, then he can escalate to Ultracet. So that's how you will have to intervene patient. Suppose if you are prescribing the drug to the patient, after cycle 1, you will have to counsel the patient. Again, you will have to taper and deprescribe the drugs for the patient. And if the patient is like, you know, with age related, you keep monitoring the blood counts and see LFTs, RFTs. And, you know, gemcitabine also have the chance of causing pulmonary toxicities. If complains any lung issues and all, you will have to rule out what is the problem in the patient and then you will have to start on chemotherapy. And also there will be so much of bone marrow suppression with this drug. So you will have to monitor blood counts and you will have to increase. Are there any special consideration for patients having altered immune function or any other immune related condition undergoing radiation therapy? Any special for patients having altered immune function? See, before you give radiation to a patient itself, see, before you start of anti-cancer treatment itself, you will have something called as performance status. You will even see whether the patient can tolerate the treatment or not. If they are, see, usually radiation is the first line of choice in head and neck cancer treatment. Okay. Altered immune function means definitely the people on cancer, the people who are diagnosed with cancer or having their immune system altered. They are immunosuppressant in one or the other way. And after receiving chemotherapy, 10 to 14 days after receiving chemotherapy, that is called nadir, where you will see the lowest blood counts of a patient. At that point of time, you will see the patient is having lowest blood counts and the immunity is very low and he's having more chance of infection. So at that point, the severity of side effects also will be more, and monitoring also, you need to take care. You should ask the patient at what day the patient started suffering with certain kind of side effects. So at that time, you will have to suggest, if the patient is something, you will have to suggest them with easily digestible foods. Usually you don't have any diet restrictions in cancer patients, except few, case to case you will have to analyze. And at the time you will have to tell them not to have any food that is very difficult to digest. That's how you will have to take care, Busa Pallavi. And another case I will just tell you. See, there is something patients who are receiving colorectal cancer on Folfox regimens. So usually what do you tell? Because patients will have loss of appetite and all. When the patients have loss of appetite, what will happen? You want to not to decrease the appetite, so that you will prescribe them with fatty food and protein food. And 5-fluorouracil has an adverse effect of diarrhea and mucositis. So you will, when the dietitian comes and gives them protein supplements or something, you will have to counsel the patient to monitor for diarrhea and also mucositis. So because of, if the patient gets an adverse effect of mucositis, his intake will decrease. And if the patient will get diarrhea, it's very, very electrolyte imbalance. So many things will happen. At that time, you will have to tell the patient, if he's having any signs of these things, you will have to stop this protein supplements. Okay. And because of mucositis, there's decrease in appetite. At that time, they can take if they don't have diarrhea. So you can de-prescribe protein supplements at that point of time and then continue. Maybe in food intake, you can increase egg or something. It is very good natural protein. If not, they'll have to discontinue. So here, even the protein supplements also you can de-prescribe. And when you see, like ovarian and lung cancers, patients are treated with paclitaxel and carboplatin. And patient is having peripheral neuropathy, is a very common side effect of paclitaxel. And the patient will start complaining of, severe nerve pain, pulling pain. They'll be telling, ma'am, I have pricking sensation in my leg. I lose senses in my legs. So usually in discharge medication contain tablet Ultracet BD. And sometimes, depending on the grade of toxicity of paclitaxel, the dosage will be modified or the formulation will be shifted. And when the intention for the patient is curative, better don't decrease the dose of paclitaxel. You can change the formulation of paclitaxel to Aqualip, because Aqualip has decrease in side effects or very minimal side effects when compared to Taxel. So there, when you change the formulation for patients who are affordable, there you need not consider adding pregabalin 75 mg ODHS for the patients. So try to avoid, when the patient is curative and beneficial, try to shift the formulation. And patient, suppose in case of patients who cannot tolerate side effects, add on supportive care medications, but don't prefer reducing the dose when the intention is curative. When it is palliative, you can check for accordingly. You have to outweigh risks and benefits, and you have to consider whether you have to change the formulation or, and the disease status, KS67 index, many things, means what is the proliferative index of the cancer also you have to check in patients. And when you see another clinical intervention that I have seen this patient also, all these have been practically seen in the wards. In multiple myeloma, in VRD regimen, that is bortezomib, lenalidomide, and dexamethasone. Usually, when lenalidomide, this thalidomide group of drugs, lenalidomide and dexamethasone are combined, there is a patient having chance of venous thromboembolism. And to prevent that venous thromboembolism in patients, as a additional supportive care medication, low dose aspirin is added to the patient. And usually in patient, you give dexamethasone IV formulation. So you can switch on to oral dexamethasone. Around 40 mg of dexamethasone will be given to the patient as a part of this regimen. So when you are using low dose aspirin, when you are prescribing, you should even have the clear cut history of whether any past history of cardiovascular disease in a patient, whether the patient is taking any other anticoagulants, because it will become dual therapy if the patient is already on anticoagulant therapy, and you will have to monitor the patient. So this also I have seen patient is prescribed low dose aspirin and some clopidogrel combination also patient was already taking. And in multiple myeloma and all, after treatment, sometimes you'll see so much of thrombocytopenia. So this would potentiate the side effects in patient. So you will have to monitor the patient very, very, very carefully. And that older age. And because of chemotherapy, sometimes bone marrow suppression is all are additional contributing factors that will cause effects in patients. So what are the barriers to deprescribing? They have limited time. Physicians need to see so many patients. Everybody, the healthcare professionals are less, patients are more. Lack of clarity over whose role it is to deprescribe. Not describe, sorry, deprescribe. Concern regarding stopping the medication initiated by specialists. Uncertainty regarding the timing of deprescribing discussions when goals of care are unclear. Concern from healthcare professionals that patients may feel they're giving up hope. Reluctance from patients to change medications. Think this, guys, small activity. Are you all there? Yes or no?
Apologies for interrupting, ma'am.
I want reply in the chat box. Are you all there?
Yes, ma'am. Sorry to cut you off, ma'am. So if you could kindly
Yes,
wind
you're
up
all
in the
there.
next
See
5 minutes
cartoon?
because we're
We
running
combined
short
all
of
your
time.
medications into one convenient dose. So this is one way, you have been seeing these days many anti-diabetic medications are coming in combinations. So you have metformin, glimepiride, you need not take 2 pills. You are having together in 1 pill.
Ma'am, am I
Okay.
audible?
Guys, can one of you give me an example for this? Each capsule contains your medication plus a treatment for each side effect. Any example? See here. Your medication and treatment for side effects. One antibiotic is there. One milk antibiotic. I told you milk antibiotic. Small age would have read one drug interaction with milk. Class of tetracycline. What is another drug? It is not tetracycline. Tell me the specific drug that you're getting in combination. See, doxycycline, guys. Yeah, very good, Kartikeya. Doxycycline with what is there in combination with doxycycline? Come on. You're Googling, I know. At least Google and tell me the answer. There's some combination of drug given with doxycycline. Come on, man. What do you take? Why you take yogurt? What is there in yogurt? What is the combination with doxycycline? Yes. Because
Ma'am,
what is the side effect of
am I
doxycycline or
audible,
adverse effect of
ma'am?
doxycycline? Loose stools. Yes or no? Yes. So You're having a drug, and even to treat the side effect, you have that another drug in that. So what will happen? You will not even, the chance of you having that adverse effect is minimized. So think in this way, that where you can go for research and you put all together in one. Sometimes combination does not work out, sometimes works out. See here, being pharmacy students, doing patient counseling, what you should counsel? It's the most effective diet pill we sell. Chase it around a handball court for an hour a day. Instead of giving them a pill, put them a ball in hand and then tell them to run over the court for an hour. Okay? Then automatically you'll put on weight. No need any pills. So pharmacists should encourage to decrease unnecessary use of medication. Okay? So it's difficult to take a decision, like people using Google and AI for their treatment decisions. So you will have to educate them. That is on information and it varies from patient to patient. Okay, it's all done. The key points. It's a common in the palliative population. Deprescribing refers to the continuation of inappropriate or unnecessary medication. So you need an evidence to support, and ONCPOD deprescribing guidelines used to support the process in cancer patients with a limited life expectancy. Any questions, guys? It's done, Shibani. I'm not taking a minute more. Any doubts you can ask, guys? Okay, if no questions, we can wind up. And thank you. And thank you, Dr. Ajit, for this opportunity.
Thank you for that clear and thoughtful explanation, ma'am. So
If
I
you have
request
any
all the
doubts, you can
speaker
ask.
and participants to turn on their cameras for a group picture. I
Shibani,
request,
it is done.
yes, ma'am. I request all the speaker and participants to turn on their cameras for a group picture now. So now moving on to our third topic today, managing medication complexity in the intensive care setting and in renal transplant patients. This topic focuses on safe and effective medication practices in some of the most critical and high-risk clinical environments. Our next speaker is Mr. Motion, a licensed clinical pharmacist currently serving as pharmacist, medication safety and quality at Sheikh Khalifa Medical City, Abu Dhabi. Prior to this, he led the pharmacy services for hemodialysis patients at SKMC and Siha Kidney Care. Mr. Motion also serves as a preceptor for the Siha PGYN Pharmacy Residency Program and is actively involved in multiple institutional and regional medication safety committees. He is a passionate advocate for data-driven decision-making in healthcare. His experience spans various roles, including his earlier work with Dubai Health Authority and as a drug information pharmacist in India. We are honored to have him join us today. Mr. Motion, the stage is all yours. Sir, you can start now.
Yeah, I hope I'm audible now to all the participants.
Yes, sir. Yes, sir.
Just 1 minute. I will add. So I will share the screen. A moment, please. I'll just quit and reopen because system is asking me to just cut and reopen. Okay, just 1 minute, please. Okay, is my screen visible to everyone?
Yes, sir, it's visible.
Okay, perfect. Let's dive into before starting our discussion. I was browsing the profile of all the participants. So what I believe that some of the participants are seasoned professional and some of the participants are budding clinical pharmacists, some are interns, and etc. So my presentation will be directed to everyone here to cater such that the participants will have maximum benefit from this lecture. So today, Dr. Ajit has requested me to present on managing medication complexities in the intensive care setting and in solid organ transplantation. Both are very different scenarios, because intensive care setting is usually a hospital predominant, whereas solid organ transplant is a mix and match between ambulatory profiles and as well as intensive and inpatient profiles. Okay, so I will finish the presentation as quickly as possible, and I want to encourage as many questions as you can. But please stick the questions to the theme of the presentation such that the other participants will have maximum benefit out of it. So let's see. My presentation have basically four parts. First is ICU and transplant services, which have the pharmacist role in pharmacist role in these two disciplines. Then comes the addressing of medication complexities and types of medication complaints across ICUs and SOTs, and then strategies to address these complexities and standing out as a clinical pharmacist while addressing these medication complexities. I have seen two presentations, and I am sure that all the eminent speakers from other areas will be speaking in detail about the strategies, but I will give you an overview of an idea that if I have to work in a tertiary care hospital or in small settings as a clinical pharmacist, how I should make best use of my available resources. So that's is an important strategy for you to stand out as a clinical pharmacist and earn respect, and how you can navigate your career. Always we cannot blame on the system level issues. We also have to drive forward. And there is a saying in management that resources are always less than what your obligations are. So what is the background between intensive care unit? Why pharmacy services are very challenging? Because there are high medication complexities, increased drug-drug interaction, very dynamic PK and PD profile, risk of organ dysfunction, very increased morbidity and mortality, and risk of permanent organ damage. Permanent organ damage can also come from the disease itself and also that unwanted adverse drug events as well. Whereas in transplant, it's a bit different. Whenever a patient has undergone transplant, it's a major surgery, life-changing decision, and risk of opportunistic infections are always there. And organ rejection leading to organ failure, other systemic drug toxicities, and even the patient may have comorbidities like diabetes, and some patients can develop diabetes because of immunosuppressants later on post-transplant. And invariably, these transplant patients also have a considerable cancer risks as well. Increased drug-drug interaction, immunosuppressants, antibiotics, antihypertensives, antifungals, etc., etc. Now, what are the stages of transplant? Why a clinical pharmacist should understand what goes into transplant? There are three stages basically. One is pre-transplant, which involves the patient listing, matching with the donor, assessment of the donor and as well as the recipients for immunization history, and also what the donor is having, diseases in their families, cancer risk of donors and recipients, etc. Because The management of the medications can also pose some significant increase in the cancer risk. Pharmacological assessment, very, very important. If you transplant the patient and the patient cannot afford the medicines, there is no way you can proceed with the transplant. So you need to understand that whether the patient, it's an expensive affair. The patient can, you have to assess that whether the patient is available, can access the medication, can pay for his insurance, etc., etc. Financial assessment and psychological assessment. It involves various individuals to objectively assess the transplant patients pre-transplant. It involves physicians, it involves surgeons, it involves other medication disciplines like GI for colon cancers, then cardiology for cardiac fitness, and any other organization, the individuals, and also the pharmacist as well. And psychological assessment, whether the patient is mentally prepared to undergo a major surgery, and what comes after that surgery also, is he committed to that. Alcohol addiction, then also smoking addiction. There is absolutely no, as per the guidelines, to proceed for those patients who are not compliant with the diet and the drinking and smoking habits. Then comes peri-transplant. Peri-transplant means whenever the donors is chosen, and whenever in case of elective surgeries, the living related donor, you know the donor beforehand. However, if it is a diseased donor, then the phone can come to the recipient that yes, we have a donor, we are planning for transplant. Can you come to the hospital? So you can just imagine that how a lot of things he can undergo through, the recipient. Then patients are scheduled for transplant. Inventory management is very important, where pharmacists play an important role. So if I have listed a patient for a transplant, whether we have immunosuppressants, peri-transplant and pre-transplant. So peri-transplant, again, we give basiliximab, anti-T cell thymoglobulin, and as well as lentuximab, whether you have sufficient quantity for that. Depending on the risk stratification, immunosuppressants can be selected. I am not going into very detail about that. Some other time we can have a detailed discussion on how they do transplant and what is the pharmacy's role, and also review of the medication prior to surgery, whether the patient is on any anticoagulants, whether there's some of or GLP analogs. So if the insulin management, or if the patient is pre-diabetic on oral hypoglycemics, he has to switch to the insulin in gradual manner, so and so forth. So there are a lot of things goes into where pharmacies are well positioned to have these things, address these managements. Then post-transplant, as soon as the patient is out of surgery, the ICU management is there, and then ward management. Once the patient is on for 2 to 3 days, urine output is good, or any other parameters of other transplant is within the acceptable limits, he will be shifted to ward. And once he's shifted to ward, we have to start working on discharge management. How the patients will be on discharge, what kind of immunosuppressants he will be, what kind of antibiotic prophylaxis for opportunistic infection, and how frequent he will be seen in ambulatory clinic. What will be the management? The best institutions practice as in a protocol manners. They will all have the protocols, and when the patient is discharged, everyone in the healthcare team knows what his or her role is. So if in our hospital, when the patient is discharged just after transplant, he will be seen for twice weekly for 1 month. Then for 3 months, he will be seen once time a week, and then for 1 year, he will be seen every month, and afterwards every 3 months he will be seen when his immune system gets stabilized. Now comes how to manage the medication complexities. Now you have understood what is the background, brief background about ICUs and as well as transplant, what pharmacy services cater for. And now we'll see that how you have to manage the medication complexities. Other eminent speakers have already spoken about Beer's criteria, start, stop, and so many tools to assess. But I will speak about medication complexity tools here in my presentation in forthcoming slides. So what is the complexity in ICUs? The basic is the contributing factor, then risk of polypharmacies, then typical pharmacist role. In ICU, there is always a chance of multiple organ failure, infection, sepsis, sedation, analgesia, and vasopressors, stress ulcers and DVT prophylaxis, electrolyte corrections, and TPN and rescue therapies as well. And what makes a risky for ICU polypharmacies? Because again, with every addition of new medication, there is a propensity of having a drug-drug interactions. Very altered pharmacokinetic due to organ failure, because one patient may respond to a medication, the other patient may not have responded to same medication with the same dose. In ICUs, the patients are more vulnerable for developing delirium, and also over sedation. There are many medications also look for QT prolongation. So you have tool to screen the patients who is vulnerable for having QT prolongations, and medication administration errors. Medication errors are one of the most contributing factors in ICU because high equity situation, medication error occur at any stage of the medication management and use, and as a pharmacist, you have to make sure that these medication errors don't occur. So pharmacists are well positioned, and they are one of the reliable healthcare professional in ICU's surroundings. Now, what is the typical clinical pharmacist role? So daily they have to review the therapy and look for deprescribing opportunities. As the other two speakers have already said, that deprescribing opportunities should also weigh into what risk-benefit ratios. So you have to prospectively also identify drug-drug interactions. Is there any duplication of therapy or inappropriate durations? Very common in the hospital settings where you don't have computerized physician ordering system. So you are basically depending on the paper files, and transcribing errors occur. So usually the junior physicians, they copy the file and conduct the pre-rounds. So if a patient is on previous day, has a 10 medications, there are fair chances that when you transcribe, all the medications may not be transcribed in the way it was on the previous papers. So it is a time consuming, it can be jarring for senior consultants to look out all the papers, and especially this is very important in case of antimicrobials. Then dose adjustment in renal and hepatic dysfunction, and participation in ICU rounds to ensure real-time optimization. Then comes medication complexities in solid organ transplant patients. I am not covering the bone marrow transplant here. I'm only covering solid organ transplant. So in this, what are the medication contributing to complexities? The cornerstone of any post-transplant patient is immunosuppression. So immunosuppression, the favorite among ours, CNIs. Then comes with mycophenolate, acid on mycophenolate mofetil, then mTOR inhibitors, corticosteroids, and you have to have a fine balance between organ toxicity and organ rejection. So any patients post-transplant comes to your office with a raised creatinine. So raised kidney transplant patient I'm speaking about. So raised creatinine can be here of two reasons. One, the drug itself is toxic because calcineurin inhibitors are a double-edged swords. It can cause kidney toxicity. However,
Sorry to interrupt, sir.
Yeah.
Sir, can you put the slide in presentation mode?
Okay, all right. No worries.
Yeah.
Okay. So the thing is, immunosuppressants like CNIs are calcineurin inhibitors, and then these are potentially nephrotoxic medications. So any raised creatinine will be either due to toxicity itself of the medications, or also undergoing rejection. So unless you do biopsy, you will not be able to differentiate what it is. So there is a very, very thin line between organ toxicity and as well as organ rejections. There's something about a mycophenolate. Then again, the risk, if the female patient's wanting to get pregnant, then they have to have a risk program. And then you have to assess that whether when she is planning for pregnancy, and you have to take off that mycophenolate in a gradual manner and put on other immunosuppressants which are friendly in pregnancy, like azathioprine, etc. Then mTOR inhibitors, corticosteroids, etc., etc. Then antimicrobial, second category of medications. Donor and recipients are contacted. I think I have not changed the slide. So antimicrobial prophylaxis, like what are the antibiotics you are giving, and then some of the antibiotics carries the toxicities also, and for how long you need to continue those antibiotics. Then there are some of the non-clinical tasks affecting your clinical work. This is very, very important. Whenever a new clinical pharmacist, they also don't pay attention to non-clinical tasks. So in non-clinical tasks, the IT infrastructures, you will be blessed if you have a good IT infrastructures with respect to informatics, and in particular pharmacy informatics. Why I'm stressing this one? Because in ICU, if you're working and if a doctor writes, it will be only helpful for the hospitals where they have the computer-based prescribing order entry. So in informatics, you have like various domains. First domain is that the availability of order sets. For example, if a patient is coming with sepsis in the hospital, as per surviving sepsis guidelines, within 1 hour he has to receive the antibiotics, he has to receive with the IV fluids, etc., etc. So this can be programmed into a order sentence. Like when I click this model as sepsis order sentence, all the parameters should come. Only the physicians or the prescriber will only take what he needs. He has to go to MRI, he has to hold the ultrasounds or any medications, etc. It is written in only in single sheet, and then once he submit the order, it goes to the relevant. Radiology will get their own, blood works, the lab can get their own orders, the pharmacy can get their own orders. So all the domains can start at a single time. And then comes inventory and procurement, very important, whether you have the right inventory available, very common, as I said, in transplant patients. And then interdisciplinary communications. So if a critical result is there, if the patient procalcitonin is very high or lactate is very high, someone from lab has to contact the physician or the pharmacist in the ICUs. So interdisciplinary communication is very, very important. And workplace and culture and leadership, how your hospital provides you workplace and culture and leadership to support your work. And then quality systems, whether proper quality systems are in place. There is someone who has to watch you on your quality work. Then comes how to measure medical complexity. Are there any scales to measure this one? So this is there are various domains, various attributes to medication regimen complexity index. One is patient characteristics. Second is number of medications. Third is dosing frequency. Four is dosing forms with any special instructions and special dosing instructions. So in ICUs, this index, there are 65 item tool quantifies regimen complexities. It's a very elaborate, but the good side is that it can be automated. Then comes the scoring is based on number of medications, dosage form, dosing frequency, and additional administration instructions. And it has been validated across various settings like chronic disease, cancer, hospital settings, primary health center settings, psychiatric hospital settings, etc., etc. You can easily find one of the sample. This is developed by Monash University, Australia. This has been validated across other settings also. And also it has a online calculator system. It's medical algorithms. You can find this one, the link provided. You have to just put the values of medications you have. So total number of medications, then second is that subscore of dosage form, subscore of dosing frequency, subscore of additional dosing instructions. So it will add up and multiply and give the final scoring for that. So how to interpret these scales, So the scale correlates with the number of drugs in a regimen, the expert consensus on drug regimen complexities, a patient's overall conditions. The MRCI consists of 3 subscores as well, which is the addition of subscore of dosage form, dosing frequency, and the additional dosing instructions. So what is the interpretation? So higher the MRCI, the more complex is the regimen, and it also can use to help us guide simplification of patient regimen and help us to identify who may benefit from more aggressive management after discharge from a hospital. So in ICUs, it is much simple. It has omitted all the remaining parameters which are not required in ICU settings. This is only a 39-item scoring system. It's also validated in multiple ICU settings and correlates with the patient outcome, such as length of stay and mortality. And also ICUs, a modified, even shorter version to have a 17-item simplified scoring, allow for dynamic assessment over time in ICUs. So if I'm working in as an ICU clinical pharmacist, I would not input individual patient data in all those parameters. To give you a snapshot of what patient you need to target, you can also use the MMRC ICU shorter version, that is 17 items, which is easy to use. Then this also available in the medcal.com. I hope many of the participants are already using this one to other like calculation of creatine clearance, QT elongations, etc., to manage their daily practice. So this is one of the best tools for them to, and it is developed by the clinical pharmacists from USA. Then comes why we need to calculate and what is the help or what is the benefit of calculating this medication complex index. The first one is risk identification. So for example, if I am working as a manager and I'm having only 4 or 5 clinical pharmacists to cover hundreds beds of hospital. So international ratio is 1 pharmacist is to 30 beds they can cover, but usually sometimes it can be overwhelming. So I have to make use of best use of my available strength of clinical pharmacists. So for that, I need to first identify the areas where my clinical pharmacist interventions have a maximum implications. By doing this, you can also explain the administrators that how valuable clinical pharmacist jobs are there in the hospitals. So this is one among the tools which can be easily helpful. So if you depute a clinical pharmacist like oncology, transplant, or ICUs, higher scores are linked to increased risk of adverse outcomes, which can also have for or provide vulnerability for a hospitalizations unintended and lower adherence among the patients. So by looking at the data, you can identify the areas where you need to concentrate more to have maximum benefit. So intervention targeting can be planned. Tools that help to identify who may benefit from pharmacy-led interventions or regimen simplification. And then the third part is research and quality improvement, used to evaluate the impact of interventions and to compare the complexities across population and settings. And you can also develop your own departmental KPIs for that, to how to enhance the departmental performance and explain the leaderships that clinical pharmacists are well in position to carry this job. So medication complexity in critical care, I said, as I mentioned, that it's a polypharmacy and drug interactions, renal and hepatic dysfunction. The patients are on vasopressors, etc., etc. So how do you use these complexities to address the problems? Now, I will give you a very, very simple example. That 65-year-old male post-op CABG patients admitted to ICU with severe sepsis secondary to ventilator-associated anemia, pneumonia, and comorbidities include type 2 diabetes mellitus, CKD, stage 3, atrial fibrillation, and apexaban, and hypertension. So based on this simple case, even in simple case, how a clinical pharmacist can play an important role with these interventions. So the first one is like antibiotic dosing optimization. Patient initiated on IV piperacillin, linezolid. Then comes drug-drug interaction check. Apixaban stopped perioperatively. Plan to resume after bleeding risk reduced. Pharmacists advise avoiding the combination of linezolid and SSRI to prevent serotonin syndrome. Renal dysfunction, again, you have to adjust the dosage of the antibiotics. TDM for linezolid to avoid thrombocytopenia and glycemic control. Recommended insulin infusion protocols based on fluctuating renal functions and steroids therapy for sepsis. And medication reconciliation, deprescribing when the patient is out of the ICU in the ward and thereby discharging, you have to suggest holding antihypertensives due to hemodynamic instability and discontinuing non-essential supplements, etc. Now comes MCRI scores of various disease populations. So chronic disease population, this was a study published which MRCI ranged from 41 to 30. 41 was higher. This is the higher percentile, which was in geriatric depression, followed to 30 in hypertension, while in lowest percentile ranged from 13 with geriatric hypertension to 7 in hypertension and HIV. Most common complexity from dosing frequency. So please pay attention to the dosing frequency. So older individuals in dementia, again in community dwelling older adults with mild cognitive impairment or dementia, median MCRI score were 12 to 14 with wide variation among those taking same number of medications who were not cognitive impaired, and then dosing frequency was the largest contributor to the complexity in the group. Again, you pay attention to dosing frequency. I will tell you why it's like that. So in cancer patients, median of 15th and discharge increased during hospitalization. Higher complexity was linked to greater perceived medication burden, which contributed to lower adherence and more unplanned hospitalization. Then multimorbidities, also the patient MRCI of 9.7 with higher scores associated with poor quality of life and more problems in daily functioning. Patients with diabetes had an average of 15.1 and higher score were associated with poor glycemic control. Why I was asking you to pay attention to the dosing frequency, because you have to simplify in dosing regimen, and it also this tool has also been studied various the healthcare settings, like settings in the sense like dosing frequency, special instruction, whether you have to look for automation is feasible or not. In oncology also, it is with MRCI score of 11 to 14. It increases during the hospitalizations because the patient undergoes with IV chemotherapy agents, besides his oral chemotherapy agents, and as well as the supportive care as well. Then primary care, it was lesser, but still the patient were older populations and have a problem of polypharmacies and comorbidities. Elderlies, again, it was very, very high, and outpatient and community, it was again in the median. So by looking at these data, you will understand that how higher MRCI score affects the patient well-being and our pharmaceutical care, So what happens? So the correlations with the outcome, higher MRCI correlations are associated with increased mortality, length of stay in the hospitals, intervention quality, and intervention intensities, and increased pharmacist workload also. So decreased care provided, because if I have a 30 patients with 15 orders, I have to review, it takes more time. Whereas I have 30 patients with lesser ordered simplified drug regimen, I will have a more time to spend with the patients to look for other problems as well. But it also associated with worsened patient outcomes, which warrants further exploration into staffing models and patient outcomes as well. So in transplant organ transplant patients, usually they have 20-23 medications daily. Newly transplant will have on very high medication burden as they have been as they undergo with the immune system stabilizations. Some of the medications can wean off. Then complexity remains very high and increasing after transplantation, and immunosuppressants and comorbidities like diabetes, hypertension, cancer risk always remain there. Then pharmacist interventions with ICUs and as well as solid organ transplant, how to address, So the first is screen at baseline regularly, So once the patient comes to you, screen at baseline, and then you have to keep on regularly screening with these tools to identify potential complexity risk. Now the situation is that in hospitals they go to multi-speciality. So if I'm working in ICU, if I'm working in nephrology clinic, so patient come to me and I will see it as nephrologist. So if I go on GI, so the patient will go to GI and he will be given on some of the medications from the GI. So as a patient, I will be catering from two different specialties, having two different medications. So there are chance of drug duplication, there are chance of drug-drug interactions. So a patient come in the morning, attends nephrology clinics, he go back to a GI clinic and he goes home. After that, we don't know what goes with the patient. So you need to have the last stop for the pharmacist to screen. Then what are the medications related problems that can arise, and you need to screen them. So simplify regimen. So for in transplant patient, I should like I mentioned that. So whenever a newly transplant patient goes home, we try to have his medications very simplified regimen. Very classic example is like we have a tacrolimus, which is a calcineurin inhibitors. It can be given BID, it can be given OD, depending on immediate release and prolonged release. So most of the patients will be kept on prolonged release. So for some reason, if the patient is not responding, his levels are not picking up in the desired level, by doing the TDM, we'll know that, and we'll keep on for those individuals only on the BID dosing to help him achieve those levels, which needs the frequent dosing. So then comes regular pharmacist interviews are very, very important, follow-up and educational support. Behavioral contracts. So behavioral contracts, motivational interviewing, and digital reminders. Why it is very important? So if I see every once I have a clinic, a transplant clinic, which I am a part of. So what happens that if a patient comes to me and if I say him that you have to take 9 o'clock tacrolimus before food or mycophenolate mofetil, if the patient wakes up and he wants to have breakfast at 8, he feels hungry. So how you have to do that? So if I tell them 9 o'clock, they will have a breakfast and then 9 o'clock they have the medication. So you have to explain to the patient that it does not mean that 9 o'clock, it means that every 24 hours at the same time you have to go, and deprescribe very judicially, start to stop. A newly transplant patient again given fungal prophylaxis for oropharyngeal thrush. We give nystatin syrup. So because the patient is on immunosuppressed, considerably immunosuppressed, and they are on high steroids when they discharge just after transplant surgery. So what we'll do that when after 1 to 3 months, if the immune system stabilizes, then we keep on 10 milligram prednisolone. Then after 10 milligram, we can ask the patient to stop that one. So slowly the medications can be weaned off. But yes, you have to have always a check and balance. So adopt technology cautiously, because there are many monitoring apps which are available on Play Store, which are available on Google Store and Google Play Stores, and as well as Apple Store, which can the patients can feed their medications information, and the applications remind them of their medications. Then comes how to strike a balance. There are some barriers to reduce this medication complexities. It happens with regimen itself is more complex, and then also it happens with changes in daily routine with the patients. You have to make sure the patients stick to one routine at least just after transplant. Physical limitation or organizational challenge. You may see the patients from 200 kilometers. You may see the patients from 500 kilometers, and then there is a logistical issue. When the patient can't come to the clinic, you should also have some sort of teleconsultation for the patients also. An absence of dedicated clinical pharmacists, which have been rampant for the specialized services. You will have only one clinical pharmacist who is covering internal medicine, who is covering ICU, who is covering everything, medication safety, quality, KPIs, etc., etc. But what are the facilitators also? So you need to understand that always have a good relationship with your administrators. That's how you will have an organizational supports. In transplant, you should also show the gratitude to the donors who has given you the organ, and you have to make sure the onus is on us, healthcare professionals, to have the organ patency. Fear of graft failure motivates you to work more in these patients. Effective use of organizational tools and avoiding readmissions. Then comes what are the strategies? Strategies deprescribing. I'm not going into very detail because already it has been spoken by other speakers. Simplification of the regimen. I said in the tacrolimus, multidisciplinary collaboration. You have to collaborate with dietitian. You have to collaborate with physicians, nursing care, very important, and transplant coordinator in case of transplant. Case management, very important. People just to how to plan their discharge. And you also can do the pharmacy related MTM clinics, comprehensive medication management. Always look for computerized physician entry and electronic order entries also. So what is the impact by doing this one? You can improve the adherence. You can also reduce the complexity up to 18%, which is already published in many data. Reduce mortality in ICU stay, reduce ordering and administration errors, and medication grid or visual tools can be utilized, and which reduces the number of medications and doses, and polypharmacies can be managed to a greater extent. So how to stand out as a clinical pharmacist? So you now saw what goes background in ICUs and solid organ transplant. You also have seen that what is the impact of medication related complex index, and you have no idea what are the services you need to identify and you need to focus on. So how, with this my limited settings in my hospital, how I should stand out as a clinical pharmacist? So let's do that. There are 3 essential skills. Without that, you just can't shine as a clinical pharmacist. One is the strong clinical skills. That is the bread and butter. If I have a very strong clinical skills, but I cannot communicate with the administrators, or I cannot speak with my leadership, you will not shine, or you will not have a good impact on the patient care. And if I'm in both, but you don't have the leadership skills, which means you can't take the responsibilities assigned for, then also you can't grow. So this also will have a mix and match of all these 3 skills to shine as a clinical pharmacist in the hospital. Now, how to do that? So strong clinical skills, very, very, very important. In-depth pharmacotherapy expertise. And I can't expect a newly clinical pharmacist appointed in ICU to have everything about that. But you have to motivate yourself to have an advanced certifications like board certifications. Where now from India also, we are getting many people who are undergoing board certifications in various disciplines. You can give BCCCP and BTXP for transplant, and as well as critical care. And if you're interested in other disciplines, even those bpsweb.org can provide certifications in other as well. Plus, there are individual organization and international societies which give masters and fellowships to pharmacists as well. One among them is American Society of Chest Physicians, which give FCCP for physicians and as well as the clinical pharmacist also. So you also have to advocate for evidence-based prescribing application. Then therapeutic drug monitoring, it's your holy cow. And then polypharmacy and deprescribing management, you have to be very, very aggressive in doing that one. You should also be a part of deprescribing clinics, very important in geriatric patients and chronic illness clinics. Effective communications, collaboration, interdisciplinary team and engagement. You being a pharmacist, we are considered as drug experts, and also you need to not shy away from giving presentations to the nursing team, to physicians, to budding students. You have to put you in well position yourself in a hospital to have a visibility, among the leadership. Plus patient care and caregiver counseling, very important. During the discharge counseling, you should have a clinics your own. Negotiation and assertiveness, this is a very tricky topic. Sometimes I may not agree with physicians judgment, but you should not defy, or you should not approach that concerns in a non-professional way. So you have to have a very effective communication skills to put through your idea, and then most of the chances and most of the avenues that the physician accepts those. Then comes data quality and safety proficiency. Medication safety data you have to analyze, and you have to set a KPI for yourself and your internal department, and how you align this with the hospital mission and goals. And then clinical audits, you have to have clinical audits and outcome tracking, and pharmacovigilance awareness, how adverse drug reactions are monitored, reported, analyzed, etc., etc. Then comes technology and digital literacy, very important. Gen Zs don't have problem. We millennials and we can are in middle of these things. Sometimes we also find it very, very challenging. So EMR utilization. So EMR is electronic medical record. You have to utilize in a best possible way to have a maximum information out of it, and you should not be based on depending on the paper-based files. Then pharmacokinetic softwares and dose calculators, you should know how to use them, and those data analytics and reporting tools. And also you have to have an educate of clinical research participation, teaching and preceptorship, interdisciplinary and scholarly writing skills. You have to start writing blogs, social media content creation, as well as you also have in textbook and guidelines authorship as well. Then leadership and professionalism can also be advocated by policy and guideline development. So if I am working in ICU and we want to have a dose tapering, dose protocols on inotrope, as a pharmacist, you should also offer your services in guidelines and policy development. And resilience and adaptability. Many new change is adapted, is introduced. So we have, as a normal human, tendency to not to change, or we have resistance to change. So don't do that. You have to be resilient and adaptable, to every situations, and make use of your own clinical skills. And ethical and patient-centered decision making, that is very, very important. You have to be ethical. You have to be patient-centered decision making. Always think yourself in the shoes of patients, and whether my interventions is harming the patient or benefiting the patients. Then comes what you'll do by having these skills. By having advanced skills, you can validate your clinical expertise. By participation in rounds, you position as an essential team member. Innovation in practice demonstrates leadership. And pharmacoeconomic mindset, always you should opt for ensures cost-effective care. And cross-training, offers versatility across area. So if I'm practicing in oncology, and if I'm not trained well in neurology, or I'm not trained in other disciplines, or at least I don't have a zest of idea, I cannot function. I cannot predict the problems what the patient may have in neurology. I cannot predict the problem what the patient may have in gastroenterology. So like that. So you should have a mix and match of all the training, but you can have hone your skills in one particular area depending on your interest. So always it's advisable to listen to other disciplines also, and have reference for other trainings as well. So here I complete. So I will be very glad if someone can ask the questions or in the chat box. So I wrapped up the presentation such that I would encourage everyone to have a question. So. Do we have any questions?
Hi, so I would like to thank Mohsin Bhai for joining us, and Mr. Mohsin, thank you very much for this wonderful session, and it was really amazing. It was really amazing, and as always, I whenever I want to understand the ICU settings, whenever I want to understand the emergency medicine or emergency pharmacy learnings, I always consider my elder brother Mohsin for this session. Thank you very much, Bhai, for taking this
Thank you so
session.
much.
Thank you.
Thank you, Dr. Ajit, and thank you so much, Dr. Motion. Sir, so for your wonderful session, we truly appreciate your time and input, sir. With that, we conclude our morning sessions. We will now break for lunch, during which the top 10 presentations will take place. This segment will be taken over by Devanshi, and we'll resume the next session at 2 p.m. sharp, so please be back on time.
Guys, take one picture also with the Mohsin Bhai and all. Can we take a picture also? Someone, please take one picture. Please click one picture also, everyone. Host on the laptop, please take some screenshots. Everyone, please open your cameras, guys. It will be great. Yes, thank you, guys. Thank you. Yes. Let's take some screenshots. Okay, thank you, guys. So we'll see you, after 2 o'clock, right? 2 o'clock we are meeting them. By the time we will take up all the presentations, and we will decide the winners. So top 10 abstracts have been selected for the presentation, and those are going on already. The presentation is going on in other I think other channels are going on. Please share the link with everyone if they wants to join the presentations as well. Okay, please send the link in the presenters link into the main conference group also, and they can also enjoy the presentations. And at 2 o'clock we'll resume, guys. Thank you very much.
Yes, sir. Thank you.